Hello, everyone. Welcome. Thank you so much for joining us today for the 2025 Spring Perinatal Substance Use Disorder Conference. This conference is supported by grant funds that are awarded to SVSU from the SAMHSA Partnership for Success 2020 grant. We would like to take care of some housekeeping items before we start. First, if you could please sign in via the chat function, please include your name, credentials, and email address. This is how we'll be keeping attendance and how we provide certificates. So the email address that's entered into the chat is the email address that we'll be sending the conference certificates to. We will have some opportunities for questions and answers as we get further in today. And so if you could please use the question and answer feature, which is located at the bottom of your screen next to your share button. We will be providing certificates after the completion of an evaluation for the conference, as long as you log in to this training and complete the proper evaluation. An email with links included will be sent following the conference. We are offering continuing medical education credits brought to us by My Michigan Health, social work credits brought to us from SVSU's School of Social Work, substance use disorder credits brought to us by Mid-State Health Network, community health worker credits brought to us by Mishwa, and sketches which are brought to us by Marquette Elger Risa. So we are going to go ahead and begin the conference with Trisha Charbonneau-Ivey providing us with an update on the state of the perinatal substance use disorder issue. Trisha, I'm going to turn it over to you.
Hi, folks. Welcome. I'm going to see if my screen sharing capabilities are actually going to work today. So we'll give it a go and see what happens here. For those that I can see, can you tell me if you are seeing my screen?
Yes, we see your screen.
Okay, excellent. Thank you so much. All right. Good afternoon. As Kim mentioned, I am Trisha Charbonneau-Ivey. I am the Associate Director at the Saginaw Valley State University Center for Rural Behavioral Health and Addiction Studies. And I am here to talk with you a little bit today about my role as the data analyst for the My Babies project, which will allow me to talk a little bit about the state of the perinatal substance use disorder issue across the United States and in Michigan specifically. So let's jump right in. All right, so our objectives today, again, we'll talk about the prevalence of perinatal substance use disorder, neonatal abstinence syndrome, and neonatal opioid withdrawal syndrome across the US and in Michigan. All right, so just so that we get started on a level playing field here, we're going to talk about the definition of addiction and recovery. ASAM shares definition of addiction with us, and that is it is a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. Prevention efforts and treatment approaches for addiction are generally as successful as for those of other chronic diseases. All right, and then let's have our basic understanding of recovery as well. This comes from the Substance Abuse and Mental Health Services Administration, or SAMHSA, and that is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. So I endeavor to use recovery-centered and person-centered language in my presentations. I will note that a lot of the presentation information comes from studies that are gendered, and so thereby I will reference when talking about those particular studies, I will use gendered language. Wherever else I endeavor to be to leave gendered language out, but I will do my very best to share those things with you as we go along. And just want to keep in mind that we'll have that recovery language in mind. Let's see. We can click. Okay, so let's start and talk a little bit about about substance misuse among the female population and co-occurring disorders. So a little bit of updated data for us. About 5.6% of women 18 and older have a substance use disorder. More than 40% of females who drank in the last month actually were binge drinking. So it's really an alarming rate of folks who were having binge drinking engagement. Marijuana use also increased to 19.8% among women 12 and older, and we'll have a little bit more detail about marijuana use and the nicotine and vaping as well. Those are some high impact numbers for the female population as well as for those who are pregnant. So the other interesting thing out of the recent National Substance Use Disorder Survey, or NSDUS survey, is that we note that 2.9% of women misused prescription pain relievers, 2.4% misused hallucinogens, 1.7% misused prescription tranquilizers or sedatives, and then 1.3% misused prescription stimulants. And so we have lower rates of things like use of heroin. It's around 0.6%, but you'll see these are sort of the top substances after marijuana. And then 8.2% of female adults 18 or older have a co-occurring mental health and substance use disorder. 69.8% received treatment for one of those conditions, but female adults with mental illness in the past year were more likely to misuse substances than those without. So sorry. All right, so here you will see a little bit of an age breakdown around substance use among females. And so SAMHSA published this NSDUS report, and it's the most recent data that we have available to us. But you will note that past year illicit drug use is highest among this 18 to 25-year-old category. So again, in the prime childbearing years of life, folks have high rates of substance use, and about 36% have had past year marijuana use as well. And this will be interesting for you as we continue to talk about substance use in pregnancy, in that folks who use marijuana sometimes and often continue into using marijuana into their pregnancy. All right, so let's talk a little bit more, dive a little bit deeper into substance use in pregnancy and what that prevalence is. So by far the most commonly used substances during pregnancy are tobacco, alcohol, and marijuana, as we mentioned. Approximately 1 in 9 women reported drinking alcohol in the past 30 days, and 7% of pregnant people use marijuana. 2020 report in the American Journal of Prevention Medicine found that both current use and binge drinking among pregnant women aged 18 to 44 in the United States increased slightly from 2011 to 2018. Current drinking, having at least one drink of any alcoholic beverage in the past 30 days, increased from 9.2% in 2011 to 11.3% in 2018. Binge drinking, having 4 or more drinks on an occasion during the past 30 days, increased from 2.5% to 4% in that same time period. So that data report comes from the CDC's Behavioral Risk Factor Surveillance System, or BRFSS. Additionally, among women who reported alcohol use, approximately 40% reported current use of one or more other substances. So we have some polysubstance use potential there as well. The CDC indicates that the self-reported data shows about 7% of women reported using prescription opioid pain relievers during their pregnancy, and of those, about 1 in 5 reported misusing prescription opioids. And that is, for instance, obtaining them from a non-healthcare source or using them for a reason other than pain. Okay. So let's talk a little bit about the considerations for substance use in pregnancy. According to the American Society of Addiction Medicine, or ASAM, women with substance use disorder have high rates of unmet reproductive health needs. While 50% of Pregnancies in the US are unplanned. The rate is estimated to be as high as 80% among those with substance use disorder. Short intervals between pregnancy may also be disruptive to treatment. Additionally, receiving inadequate substance use disorder treatment is associated with poor adherence to prenatal care, attention to maternal nutrition, and worsening of co-occurring psychiatric illnesses. Sounds like a perfect storm, right? So additionally, pregnant women with an SUD are even more likely to have a co-occurring psychiatric illness and often face a whole host of psychosocial stressors. Women with SUD have higher rates of exposure to adverse childhood experiences and potentially traumatic childhood events, including sexual and or physical abuse, and are more likely to be in a current or recent violent relationship. These home environments can also complicate or contribute to poor health and compromised well-being of pregnant and postpartum women and their children. Some pregnant women with substance use disorders experience housing and food insecurity for themselves as well as their children in their care. Child Protective Services involvement may need to occur, but can disrupt important maternal attachment, especially with a newborn child. Unfortunately, pregnant and postpartum women with SUD frequently experience stigma and discrimination from healthcare providers as well as the public at large. Recently, public concern for preventing fetal harm has resulted in some states implementing punitive measures against pregnant or postpartum women. These measures have included incarcerating women who are pregnant and using substances. The adoption of CAPTA in 2010 required all states to develop policies around reportable events related to substance use disorder and pregnancy. However, it's critical to note that some states' reporting requirements have led to these punitive consequences. Punishing pregnant women impedes proper medical care and the promotion of public health. And it's of note that it's also having a huge impact on data and data self-reporting, which is what we're really relying on in this type of surveillance. So let's go to the next slide. Let's talk a little bit about approximately 5% of all people who are pregnant have a substance use disorder. 18.1% of pregnant women report marijuana use in the past year, and they met criteria for marijuana misuse, dependence, or both. We also know that the number of women with opioid-related diagnoses increased by 131% between 2010 and 2017. I'm sorry, I know that's a little bit dated, but that seems to be the most recent information we have. And opioid use disorder is also associated with a 4.6-fold increase in maternal death during hospitalization. And not only is it during hospitalization, but we note that through a record study by Schiff et al. In 2018 in obstetrics and gynecology, that opioid overdose risk trends are highest earlier in pregnancy, with the lowest risk occurring in the third trimester, and then about 3.3 per 100,000. But that risk becomes highest postpartum, 7 to 12 months after delivery, with a rate of 12.3 per 100,000. So of note is really that overdose death rates for those in pharmacotherapy-based treatment or receiving medication for addiction treatment were lower than those not receiving treatment. So this was found to be of significant statistical significance in that 4 to 6 month postpartum period. And when that 1.3 per 100,000 on treatment versus 10.7 per 100,000 for those not on pharmacotherapy for their opioid use disorder. So let's take a look at what that maternal mortality rate looks like. We'll take a quick peek at that. You'll see that pregnancy-associated mortality by prosperity region in Michigan is here before you. You will note that the Northeast, East Central, East Michigan, and Detroit metro areas have the highest rates, and they are above the Michigan average. So those are predominantly rural communities and or very metropolitan communities, all of which are often considered underserved. So, but it was the substance use disorder was the leading cause of pregnancy-associated mortality in Michigan. So you can see there that cause, the substance use disorder cause is 29% of those mortality. So let's talk a little bit about fetal alcohol spectrum disorder. What we know about the outcomes of substance use during pregnancy is predominantly around alcohol use. So we don't have a lot of other studies around outcomes for children exposed to other substances or long-term outcomes, but you will note that this includes several diagnoses related to exposure of the baby to alcohol during pregnancy. More specifically, fetal alcohol syndrome is the most involved diagnosis. Oops, sorry. Used when several physical and developmental abnormalities are present. So about 0.3 out of 1,000 children 7 to 9 years of age have FAS, while in-person assessments show higher rates of about 6 to 9 out of 1,000. So experts estimate that the number of children with fetal alcohol spectrum disorders to be about 1 to 5% of the population. All right. So let's talk about NAS and NOWS. So what we understand about NAS is it occurs when a child is born exposed to a substance used by a mother and develops infant develops a passive dependency to the substance and expresses symptoms once the supply of drug is terminated after that birth. So the rate of NAS among infants peaked around 837.1 per 100,000 births in 2016 and decreased from there to 624.1 in 2020. The highest county 3-year rates were in the northern portion of the Lower Peninsula and the Upper Peninsula. So again, those rural and remote communities in Michigan are hardest hit by these numbers. Infants with NAS often have longer hospital stays and have higher overall costs for care. Okay, let's look at the intersectionality between rurality, substance use disorder, and NAS. So wonderfully, the Michigan Department of Health and Human Services Division of Vital Records has these statistics for us. And as you can see in the darkest blue, our Upper Peninsula has the alarming rate of 20.2 cases of neonatal abstinence syndrome per 1,000 live births. And regions 3, 5, and 6, that second darkest blue color, have rates that are above the Michigan average and are some of the highest in the state. Again, some of our most rural communities and underserved communities. So nationally, we know over 21% of all infants born with NAS were born in rural communities. All right, let's take a look at some information from Michigan Department of Health and Human Services on neonatal abstinence syndrome based on maternal race or ethnicity. And this is a 2022 update. They have been monitoring this the last couple of reports that they've produced. And you will note it is significant, the impact on the American Indian population in Michigan. The NAS rate is truly astounding. That disparity is truly astounding. So we are hopeful for those strong connections that have been built between tribal leadership and recovery community that will help to address some of these significant disparities. And there have been significant efforts across the state to increase the resources available to the tribal population around maternal care and substance use disorder treatment care. Okay, so as we develop more robust surveillance systems, it allows us to deepen our understanding of the impact of substance use on our community, empowering us to better develop responsive policies that support the compassionate, timely, and effective delivery of treatment to people who are pregnant and their children. Thank you so much. The next are my references, which you will be able to see once those are published on our website. And thank you so much. I'm going to turn it back over to Kim.
Thank you so much, Trisha. So now is the time in our conference where we are going to turn it over to Dr. Jeffery Cooper from Billings, Montana, to talk with us about neonatal abstinence syndrome. Thank you, Dr. Cooper, for joining us today. Oh, we cannot hear you.
Can you hear me okay now?
Yes, we can hear you now.
Sorry about that issue. Thank you so much for having me. I'm going to attempt to share my screen. And thank you so much for SVSU, the Perinatal Substance Use Disorder Conference. I'm honored to be here. And Trisha, thank you for presenting very thorough data for the state of how things are in Michigan. We'll talk a little bit about that, but you did a really good job of summarizing everything we need to do. Is it okay if I run my PowerPoint from here?
Yep,
Can you guys see it okay?
we cannot.
Oh, okay. I will see if I can share my screen. Let's see. There we go. How does that look? Better?
Yep.
All right, I'll start my slideshow then. Okay. So thank you so much again for this opportunity. I have no disclosures to share with you at this time. Just a little background, I've been a practicing neonatologist at the Billings Clinic here in Billings, Montana for the past 10 years. And I've been presenting in Michigan for the past 3 years, I believe. So today we'll talk a little bit about our objectives. We'll define neonatal abstinence syndrome and neonatal opioid withdrawal syndrome. We'll talk a little bit about the prevalence of NAS and NOWS, which Trisha touched on a little bit. We'll just touch it briefly. We'll identify clinical presentation of NAS and NOWS. And when it is identified, we'll discuss both non-pharmacologic as well as pharmacologic management. And then we'll implement best practices for discharge and follow-up. So basically to define, obviously, neonatal abstinence syndrome, NAS, so I'll use from that term now. And then for NOWS is the neonatal opioid withdrawal syndrome. In the literature, both terms are used interchangeably. Specifically, though, NOWS is referring to infants born to opioid-using mothers, and that could be anyone who's using opioids for pain that's prescribed or someone that's even abusing opioids. And then NAS typically is used for infants born to mothers who are doing polysubstance or other substances other than opioids, most of those being illicit substances. When we talk about NAS or NOWS, it's a clinical diagnosis. And what we see when these babies are born is that it's an abrupt discontinuation of a chronic fetal exposure to substances used during pregnancy. So the mom's, whatever substance that she is using, once that umbilical cord is clamped, then there's an absence of that substance getting to the baby, and then that withdrawal is what we're seeing symptoms of. It's a multi-system disorder, and we'll get more into details about this, but it involves the central and autonomic nervous system as well as that kind of the GI tract. And so when we get into symptoms, you'll see that more specifically. So for the purposes of this lecture, I primarily use NAS exclusively to refer to any infant born to a mother using one or multiple substances, whether they would be legal or illegal during the pregnancy that has withdrawal symptoms. And you can see this is a very, very large spectrum from the, like I said, the mother who has chronic pain, who's taking prescribed opioids, to the mother who's obtaining it from other sources and using it inappropriately. Some people like to use the term withdrawal. It's a more kind of appropriate term, and that's understandable. But for simplicity, I'll just use NAS for this talk, knowing that it crosses over, and sometimes we're talking specifically about opioids. As Trisha did a really great job presenting, the prevalence of NAS is about 6.2 newborns for every 1,000 births, and that's the US data we currently have. It's about 80 newborns per day that we see are diagnosed with NAS. Specifically, like Trisha mentioned, when we talk about the NAS prevalence in Michigan, this is data pulled from ICD-9 codes, and then when we change to ICD-10 codes, you can see there. And you can see, like she was talking about, the 130+% increase starting around 2009 all the way up to about 2015, 2016. There was quite a jump in the diagnosis of NAS, which correlates with moms using more substances. But I do also want to point out, while there's a sharp increase, Michigan has done a fantastic job in addressing this. You can see there is a decline starting around that 2016-17 mark, and it's continuing to drop. and even want to focus in more on that 2020, 2021, because remember, we went through a little thing called COVID. It really uncovered a lot of mental illness that was prevalent in the community, and still Michigan has done a great job keeping those numbers low. I know there's more to do, like Trisha was talking about, but I just want to commend you guys on the great job that you're doing there on these numbers. Of course, as Trisha mentioned too as well, there's a very complex process, and one of the things that affects the incidence of NAS or the prevalence is perinatal stressors. And being pregnant with a family is stressful, but also moms that are receiving suboptimal treatment for their substance use disorders can affect that as well. Anytime you have long-term unemployment, that can stress your life as well. And then, as you know, a shortage of mental health clinicians and clinics or places for people to get the services they need can affect that as well. Moving on to the clinical presentation of NAS. So, it really just varies by the different substances or drugs that are used. And so we'll talk about different categories here. The severity may not necessarily correlate with the dose or duration of exposure. So this can be very frustrating. You may get a history of a mom who's not taken much, but the infant's showing increased signs of withdrawal. We do know that narcotics provide the earliest studies and sort of the clearest picture, the best studied, and we'll talk about that one in detail. And those, when you talk about narcotics, the spectrum includes things like morphine, heroin, methadone, prescription opioids, and other substances and the like. So when talking about narcotics and barbiturates, you can see withdrawal in the infants from as early as birth, and some of the substances like barbiturates can last days to sometimes even months. You can have withdrawal symptoms. As I mentioned earlier, you have central nervous system and the autonomic nervous system, as well as GI systems that are typically involved. Less common systems are respiratory and integumentary, or the skin type systems. Signs of the central nervous system withdrawal of opioids can include things like increased tone, tremors, increase in reflexes. These infants typically are more irritable, they're restless, have difficulty settling down, can present with a high-pitched cry, do not sleep and settle as well, and occasionally in worse severe cases, we do see seizures in these babies from the withdrawal of the substance. The autonomic systems we see in these babies are sort of sweating, they have a little more low-grade fever, they tend to have a little more nasal stuffiness, sneezing and yawning, and the integumentary we talked about with that skin modeling. The GI symptoms we see typically in these babies include things like diarrhea or looser stools. Occasionally they can present with vomiting with the feeds. They tend to feed poorly. They may act very hungry, but once they start to latch and work on nursing, they may not nurse as well. They may have difficulty with swallowing. And then because of the feeding and swallowing and diarrhea, they may present with a little bit of failure to thrive and have poor weight gain and poor growth. So when we dig into the pathophysiology of opioids, it's studied and we're learning more and more as we go along, but there's still things that we don't understand. We do know that opioid, they transfer easily across the placenta. So whatever the mother is taking does get to the baby. That kind of goes without saying. We also know that as the baby gets closer to that term due date, that transmission does increase as well. And so, if we can get the moms treated and we can get the decrease in the usage or elimination of the usage, that is beneficial to babies. They get closer to being born. And then withdrawal may worsen based on the ease of crossing into the blood-brain barrier, as well as the prolonged half-life of the substance that their typical substance that they're using. So it's kind of a complex biological phenomenon, and it tends to be harder to study and more complex in neonates. And the reason is the neonates are very immature neurologically. They're still doing a lot of developing, as anyone who's had kids or spent time with children or infants can tell you. They have impaired neurologic processing. And then, of course, anytime a mother takes something, there's complex maternal fetal placental pharmacokinetics. Specifically, when we start talking about what happens in the brain, we see that there's opioid activity in the locus coeruleus of the pons of the brainstem. It's very sensitive to the opioid status. So the locus coeruleus is the primary center for release of norepinephrine. And so this area of the brain and the release of norepinephrine can affect things such as arousal, attention, cognitive function as you get older, anxiety, and stress responses are found there as well. And so that lack of opioids, when they're suddenly taken away, leads to an increased production of the norepinephrine, which can affect that as well. When we speak about the ventral tegmental area of the midbrain, that's the area that releases a lot of dopamine. And so when we have a withdrawal of opioids, then that simultaneously releases less dopamine. So the ventral tegmental area is associated with reward, motivation, and very well studied with addiction. And so you see, when you have less dopamine, it's the less pleasurable part of the brain as well. And then you also see decreased serotonin release in the dorsal raphe nucleus. That's also in the midbrain. And so that's involved with things such as mood, anxiety, pain, and sleep. And so obviously decreased serotonin, decreased sleep in these infants, and that's sort of the symptoms we were talking about earlier. And there's a more detailed picture we'll go through here in a little bit. With the withdrawal of opioids, you do see increase of other neurotransmitters such as acetylcholine, and then it may activate the pituitary axis, leading to an increase of corticotropin release or stress hormones as well. So this affects their development early on as well. So the slide I have here is kind of very busy, but I'll just start in the middle. You have sort of at the top in the middle the delivery of the infant. You have the withdrawal of the opioids, says you cut the umbilical cord, you lose that connection to the placenta. You have an increase in adenyl cyclase, which increases cyclic AMP, which elevates transcription factors, which affects release of neurotransmitters. So starting about 1 o'clock in the gray bar, that's your noradrenaline or norepinephrine. This is released from locus coeruleus. So if you do have an increase of that, it leads to hypothermia, hypertension, tremors, and tachycardia, which we see in our withdrawal symptoms. Moving around the dial, you see acetylcholine. As that is increased, you see diarrhea, vomiting, sort of yawning, sneezing, and sweating symptoms. Down below, when you have that HPA axis disturbance, you have that corticotropin or stress hormone release, which leads to infants appearing to act hungry. They appear to want to eat all the time. And then when you have a decrease in your serotonin, that's affecting your sleep. So these babies have difficulty falling asleep. They have difficulty staying asleep. And actually, they tend to sleep better being held than they do in their bassinets or cribs. And then obviously decreased dopamine, you have hyperirritability and anxiety as well. So that's how these babies can also present with some of these symptoms. So we talk again about the pathophysiology of opioids. You have there are some genetic variations of the mu-opioid receptor and the OPRM1. So the OPRM1 affects how opioids are received by the receptor, and there's different variations that show that some receptors receive opioids very well, and there's an immediate response, and some don't receive it as well. And the ones that are really upregulated and work well, they're the ones that are more concerning. Those patients have more concerning risk for addiction versus the general population. You can also see the COMT, or the catecholamine methyltransferase. That's an enzyme that helps metabolize some of those catecholamines. So if you're not metabolizing them as quickly, if they're sticking around longer, such as the norepi has been upregulated, then that's going to affect obviously the tremors, the tone, and things of that nature. They both appear, like I said, to affect the need for pharmacotherapy and length of stay in some infants. And then we've done studies that show that epigenetic modification of certain of the OPRM1s do affect NAS severity. Now, we typically don't test for that, But when you're taking care of these babies, some babies seem to respond very well to treatment, and some seem to not respond as well and take a little longer to get over the symptoms. And there's definitely a genetic component that's playing into that. Moving on from opioids, when we talk about stimulants, these are things like methamphetamine and cocaine. So methamphetamine here in Montana is probably the most commonly abused substance that we see our moms using. Obviously, we see marijuana, a lot of marijuana use now, but as that's becoming more and more legal state by state and county by county. But methamphetamine still is considered illegal here, and we do see some moms using methamphetamine. The withdrawal symptoms in these babies are shown to less likely to need pharmacologic treatment, which is good. But these babies present with similar symptoms to opioid withdrawal. They have the tremors, the high-pitched cry. They're very irritable. They appear to really want to feed a lot, but don't feed so well. They're more alert, don't sleep as good. Occasionally, they can present with pauses in breathing or apnea, and obviously fast breathing at times. We have seen, though, the slightly higher rate of prematurity with methamphetamine use, intrauterine growth restriction, so these babies come out a little bit smaller, and some perinatal asphyxia, so interruption of blood flow to the brain, which can affect them and can be very devastating. And a lot of times when we're talking about things like methamphetamine, this can be complicated by, as Trisha mentioned, poly drug use, so other substances as well. Usually it's one or two, sometimes three substances that you see. It wouldn't be unusual at all. Moving on to depressants and sedatives. So specifically focusing on ETOH or alcohol withdrawal. That usually begins 3 to 12 hours after delivery. And those babies present with physical findings of fetal alcohol spectrum disorder. And so there are ways to diagnose that clinically by looking at the face and the presentation to see kind of the degree of that the infants are affected. The severity of the withdrawal, though, is much lower. And then I don't see this as often, but the sedative hypnotics can present a few days after birth. And so that's kind of concerning. If a baby's doing good for 24, 48 hours, a lot of our mothers and babies tend to discharge in that first day or two, especially vaginal delivery, but it's concerning if some of these start to show up a few days later. I put SSRIs in here because infants are affected by them. Most of the moms that we see that are taking SSRIs are prescribed for a variety of reasons, the most common being depression and generalized anxiety disorder that we see here. These babies tend to have signs shortly after delivery with tremors, increased muscle tone. They don't quite sleep as well, a little GI disturbance, and can have kind of high-pitched cry. The good news is that a lot of these symptoms are self-limiting and only last for 2 to 4 days. And as far as my recollection is, I have yet to specifically pharmacologically treat an infant that's going through an SSRI withdrawal. So just something to keep in mind, if a baby's having symptoms and you're kind of concerned, taking a look at the mother's history, what she was prescribed and taking prior to delivery can affect that as well. I mentioned kratom. It's becoming more and more popular at some of our dispensaries here in Montana. You'll see signs for CBD gummies and kratom and other substances. So this is found on a leaf in Southeast Asia. The active portion of it is the mitragynine, I think is how you pronounce it. And actually that binds to the opioid receptor. A lot of the kratom that's sold around Montana specifically is not well regulated. It's not an FDA regulated medication. So there's varying degrees of concentration and potency of the kratom. As far as I know, this is still not yet detected on urine drug screens. And we send, and I'll talk about this later, a sample of the cord here at our NICU, and it's not detected on our cord drug screens as well. These babies present with jitteriness, hypertonia, irritability. They're kind of sweaty a little bit, feeding intolerance, and loose stools. So these symptoms are very similar to the other symptoms that we saw with other substances as well. And then these present around day 2 of age. And so it is classified as an opioid, but it's really largely unregulated. But I do want to take a minute and talk about Michigan specific. So this in 2021 shows the legality, and there's new information now, so don't take this to heart. Michigan's gray, just like Montana. Some of us, you could see the variation in different degrees where kratom is banned. Some states with partial restrictions, in some states even in the green where it's legal. But most states, it's so far as 2021, it's largely unregulated. But I think that's going to change over time as we bring more, if we bring more awareness to the issue. So this is a map in 2020, and it's different than 2021 because around that time, Michigan was presenting legislation what to do about kratom and whether how to address it. And so in 2021, there were about 103 drug-related deaths involving kratom in Michigan. And this, I don't want to cause too many alarms. This wasn't primarily kratom alone, but it kind of goes into that polysubstance use where it was kratom with other drugs as well, other substances. And so you can see, though, it's something to really kind of keep your eye on. And there was a House bill in Michigan, number 4061, that was passed last year in January 2024 that does regulate kratom in Michigan. So good for you guys. I hope that our state will follow suit with other states as to whether we deal with this issue rather than kind of let it go unregulated. I mentioned xylazine. This is kind of a new, it's been around, but it's seen in veterinary medicine. It's an alpha-2 agonist, sort of creates sort of a sedative as well as an analgesic effect. And so it's been reported to be an adulterant in heroin as well as in illicit fentanyl. So getting back to that, it's not always clear it's one substance, but it can be multiple substances interacting. And so just something kind of to throw it out there to raise awareness to these things that are coming down the line. I've not seen this yet, but I think it's starting to show up. People are starting to study it a little bit and see it. So how do you confirm what the infant has taken? So a lot of times we do, well, I should say, we do ask our mothers when we admit babies to our NICU, we get a really good history. And so, you know, we're not here to judge. We're just trying to treat the infant as best we can. And so when we talk to these moms, primarily we're asking them, is there anything, you know, that you might have taken that might affect your infant? And not always they're very forthcoming, but when we do see signs of withdrawal, then we tend to circle back with the mothers as well. And just again, touch base and say, hey, we're seeing these symptoms, your infant's doing these things. Is there anything else that, you know, we need to know about to help take care of your infant? And I will say that most mothers are willing to share with us what's going on, because I think deep down there's a sense that they want to do what's right for their infant. And we also want to do what's right for their infant. So when we talk about confirmation of substances, the meconium is probably the one that I remember the most from residency several years ago. It's more sensitive than urine, and you can get a window of detection from about 20 weeks. So there's a long period of time in that last few months of pregnancy that you can detect what the mom has been, or what the baby's been receiving from the mom. The urine is also more popular. It's easy to collect, but as we know in deliveries, a lot of babies tend to pee during the delivery process or right after delivery. So catching that urine is usually, by the time, if you don't know about anything, you've missed that first urine, but certainly something you collect. And then other ways you can test is cord or hair samples. So hair always, to me, seems very, it hurts when my little hair that I have on my head gets pulled. So I think pulling hair on babies seems kind of harsh, but we do send a sample in our NICU for every admission of the umbilical cord, a small segment of the umbilical cord, for drug testing, because we've decided as a group here that rather than rely on our judgment, we just decided to test every mom that gets admitted to our NICU. And so I always tell our mothers, you know, if my wife were delivering here, we would send a sample of her cord as well, looking for those things so that they know we're not trying to judge anybody. We're just trying to find the best way to test if these babies are having or been involved in any use or anything like that. So when it gets to reporting, obviously there's very state-specific laws. We rely heavily on our case management, our care managers, who work closely with our child and family services. I did include this link here. I did not check it today, but it's a link that gets you to a more state-specific reporting. And so each state has their own different guidelines. So you can go through the guidelines of Michigan and know what's required for to you know, per the law, so that you're also reporting the things that you need to report as well. So management approach with these infants, obviously this is a multidisciplinary approach. So we involve in our unit, you know, we have our occupational therapists, our physical therapists. They're very good with neurodevelopment and oral motor coordination with feeding. We have our nurses highly involved, as well as our providers. And we really try as best we can to involve the parents as much as possible. And I'll go into kind of, obviously that goes without saying, but we'll go into how parents can really help us a lot with these babies that are going for withdrawal. And so our goal is to minimize the signs of the withdrawal and to promote infant and parental regulation. And so I always say it's important for us to try to reunite these infants as long as it's safe with their family members, and to do that in conjunction with our care management and our child and family services to do that in a safe, positive manner, to get these families the treatment they may need and get them on the right track as well. So there's several different ways you can score these infants. So the one that I'm most familiar with, and I put here on the top, is the Finnegan scoring system. And I say that because I've used it at the 3 different units I trained and worked at. It looks at 20 different signs in the neurologic, respiratory, and GI categories. It takes a total score. So typically if your scores are 1 to 7, we consider those very mild symptoms. Typically, if we see 8 or more over 3 scoring periods, or on the higher end, 12 or more over 2 scoring periods, we consider that very more severe symptoms. There's also the neonatal withdrawal scoring system, the Austria criteria, the neonatal withdrawal inventory, and the Riley infant pain scale. I think the important thing I just mentioned here is to find a scoring system that you and the staff are comfortable using, that you can be as consistent in that scoring system as well, and so that you get the most objective data. As we know, these scoring systems are not perfect. There's and especially when you're using substances other than opioids, because they were primarily studied with opioids, they're not the best, but they are better than nothing. So I do recommend using them and kind of following those. This is a picture. It's a very busy slide. You don't have to read all the data, but this is a typical Finnegan scoring tool. So you can see the numbers in the black, anywhere from a 1 to a 3 to a 5 in the extreme cases. And then you just we try to have 2 of our trained staff do scoring side by side. We try to score the baby after they're being fed. We feel like if they're hungry and wanting to feed, and we're trying to score them, it's just you're going to get higher scores. So we try to kind of feed them, change them, get them to settle down, and then we try to do the scoring system to get the most objective scoring we can. And I think having the 2 reporter at the same time is also helpful, so you get sort of a little more better objective score for these babies. So quantifying the severity of the NA, I just wanted to go back, sorry. And just kind of the categories, you can see the general categories, the CNS, they're on the top. Then you have sort of the vasomotor or respiratory, sort of the autonomic type symptoms with the respiratory symptoms in the middle. And then the GI, we talked about the 3 categories on the bottom. So those are kind of the things we're looking for, which we talked about earlier on the symptoms there, just a way of quantifying that. So what helps determine, in our cases, the need for pharmacologic therapy. So our guidelines say 8 or more for 3 scores, or 2 scores of 12 or more. We typically will consider starting treatment. Also, as we start treatment, we continue to monitor, and as the scores go down, it helps us in titrating and also stopping the therapy. And as I mentioned, it's best after the feeds at 3 to 4 hour intervals while the infant is awake. Very useful for term infants, but it's very problematic in our preterm infants, especially our late preterm that are born at 34 to 37 weeks. It's very tricky, very difficult. Now let's talk about non-pharmacologic care, and this is probably the most important piece of the treatment. So this is the best in cases of mild withdrawal. And the reason is we're trying to help these infants overcome these withdrawal symptoms without intentionally introducing more substances if we can avoid it. So we embrace things like gentle handling, on-demand feeds, swaddling, and we try ambient noise and light control, so a quieter environment, decreased light. We know that swaddling lessens their stimulation and decreases the crying time. It's very effective. Minimal stimulation includes dim lights and low noise. And we actually have a cuddler program in our NICU. We have volunteers that come to spend anywhere from 3 to 6 hour shifts. And these babies are usually high on the list for cuddling. They do very well being held and cuddled. And then we also offer frequent feedings, and we try to offer a higher caloric formula if they're not taking maternal breast milk, or, in the cases of moms where they're taking prescribed opioids, we do want them to get maternal breast milk, and some of that kind of helps with symptoms as well. And so we sort of kind of do a hybrid approach there with the feeding. Now let's talk about Eat, Sleep, Console. This is the method that's becoming more and more common in units. It's a function-based assessment of withdrawal severity. So basically, just like the title says, I like this because it's simple. You're focused on the infant's ability to eat, the infant's ability to sleep, and their ability to be consoled with non-pharmacologic interventions. And so very simply, you're saying, can the infant eat 1 ounce or more of formula or breastfeed well? Can the infant sleep more than an hour at a time? And can the infant be consoled within 10 minutes? And so those are the goals. If you can achieve these goals, you can help these babies with their withdrawal symptoms. And that's why we really encourage parents to be involved. It's a very, it mimics what you should help these infants do anyway when you take them home. I mean, you should be feeding them well, they should be sleeping more than an hour, and should console easily. So it's a very, very effective strategy. And so, like I said, eating fine, sleeping, and can they be consoled? And that's in a nutshell, eat, sleep, and console. It's been shown in a meta-analysis to decrease hospital stay, which is fantastic. We can get these babies home quicker, which is more beneficial. It decreases morphine use, which is great. So we're not giving them an extra pharmacologic treatment. And the cost, if you can decrease costs, this is very well done. So in the New England Journal of Medicine in June of 2023, they came out with the Eat, Sleep, Console approach or usual care for neonatal opioid withdrawal. And this is the first, there were several case studies and meta-analysis. This is the first randomized controlled trial looking at this. And so what they did is they took infants 36 weeks or older being treated for withdrawal. And so they divided them into the Eat, Sleep, Console side, and they divided them into the usual care group. And the important things to see is there was a very big difference in length of stay. You can see there was almost just about in half as much time they spent in the hospital versus the infants in the usual care group. And the opioid treatment, while they did receive some opioid treatment breakthrough, it was much, much more decreased in the Eat, Sleep, Console than it was in the usual care group. And thank goodness the safety outcomes were also similar. So this is becoming, I think, the standard of care across the nation in infants that are suffering from withdrawal as well. On On a side note for pharmacologic care, there's no uniformly accepted pharmacologic intervention or standardized treatment. When we start thinking about, do we need to start treating these infants? We kind of look at a couple of things. Have we exhausted all cases of supportive therapy and the infant's still showing withdrawal symptoms? Are their scores remaining high despite our eat, sleep, console methods there? And then serious signs such as seizures or that nature, certainly that's very severe, something we want to treat. And then we look at, as the baby able to eat, are they able to keep food down? Are they able to gain weight? Or are they starting to lose weight and severely because of diarrhea and vomiting? Then maybe they would benefit from treatment as well. The risk or the double-edged sword of treatment is if you delay treatment, that has been shown to be associated with higher morbidity and longer hospital stay. So it's very difficult in these babies. You want to do supportive measures, you want to do eat, sleep, console, but also you don't want to delay treatments in cases of severe withdrawal because you don't want to accidentally prolong hospital stay on the other end of the spectrum. So when we talk about different medications and we talk about opioid antagonists such as naloxone, this is contraindicated because you're cutting off those opioid receptors and it does lead to an increase in seizure risk. And so we're seeing that recommendation to not use naloxone. People in the past, long ago, have used paregoric or tincture of opium. They do have high alcohol contents and toxic chemicals. We do not recommend using those. When we talk about using sedatives, there's just complications with those, and the prolonged half-life lasts a long time, so it's not very straightforward. So those ones these are all ones that are falling out of favor for treatment. But the most common and the one that we have on our guidelines is morphine. And the good news is morphine has been shown to decrease the incidence of seizures. It improves infants' feeding. It eliminates the diarrhea or loose stools, decreases the agitation, and helps control severe symptoms. So we have a guideline that have a starting dose and how to titrate up and how to titrate down the morphine. And typically if we start treatment, we treat every 3 to 4 hours. The drawback is if you are treating with morphine, it does prolong the hospital stay, so that can be a problem. Obviously, you do want to treat if they need treatment, but you don't want them to stay longer if you can avoid it. So trying to find that balance there. And then icing on morphine is you can quickly escalate it for rising scores, and then you can do a gradual taper. We usually decrease our dose every 24 to 48 hours as scores improve. Other units use methadone as an alternative to morphine. The nice thing about methadone is it's administered twice per day, and its morphine is administered every 3 hours. The dose, just like morphine, can be increased or decreased depending on the severity of the scores. So as scores get lower, you can start to taper that dose. And I've even heard of some units in Michigan specifically where they run a methadone clinic. They're able to stabilize the infants, send them home with reliable parents, and follow up in a weekly methadone clinic to wean them down. Buprenorphine is a newer option starting to be used, but it has a high alcohol content, so just kind of keep that in mind as well. You want to help these babies and try to minimize harm as much as possible. Now, if we start morphine and we're starting to ramp up the dose and we're still having high scores, we do have adjunctive therapies. The most common that we see is clonidine. And so we have on our guidelines, when you reach a certain threshold of morphine, then we add on the clonidine. And that helps to decrease length of stay. It helps to sort of, so you're not going up and up on your morphine, to help sort of stabilize that. And so it's been shown to be beneficial. Other medications are phenobarb, can also decrease length of stay, but it has also a high alcohol content, so that's a concern as well, but something that can be considered to be used in addition to morphine. So these two are not standalone therapies, but are used in addition to things like morphine or methadone. Okay, so now we've sort of been scoring, we failed each console, we've treated, our scores are down, and so we typically withdraw our, we're no longer needing any morphine or any other device to help get them lower on their scores. So how do we decide to discharge these babies? So typically in our unit, we'll watch them for about 48 hours after the last dose of medication. We keep an eye on their withdrawal symptoms, make sure they stay diminished, make sure the scores are low, make sure the infant is feeding well, sleeping well, easy to be consoled, and gaining weight. And this is where we work, again, with our parents. We work really hard with them to teach them what their baby needs, how to intervene, how to support them, and help them get through these symptoms so that we can get them home. We also want to make sure that parental functioning and mental health is a big deal. You know, are the parents in getting the mental health support they need? Are they able to handle these symptoms together? Those sorts of things. Are they getting support for their substance use? Are they getting treatment? And we rely on our child and family services here as well in Montana to help make sure our parents are safe to take home, to make sure they're getting the treatment they need. And then we want to make sure they have the right home environment and the right supportive systems as best for these babies. And then we definitely recommend follow-up after they leave our unit within 48 hours. Obviously on a Friday, we try to get them seen by Monday. And our pediatricians and family practice doctors in the region are very good about opening spots for babies that have been discharged for the NICU. And then any other sort of follow-up you might need. So whether they need if there's some strabismus going on, they need to see ophthalmologic care or any sort of neurodevelopmental follow-up. If there's a NICU follow-up clinic, these kids are prime candidates for a NICU follow-up clinic. Or in our case, we have a chronic care kind of high-risk clinic that's run by one of our pediatricians that sometimes the higher risk ones, we try to get them in to see the high-risk clinic there, the chronic care clinic. So get them evaluated and taken care of. All right, there's a list of a few of my references here that I've got for you. And that concludes my talk. I'm open to any questions that any of you might have. I'm happy to answer those for you. And thank you so much for your time.
Thank you so much, Dr. Cooper. So we do have some questions for you. Our first question is, Kratom states that have it legal. Do they regulate it?
So my understanding is, and looking kind of briefly at the Michigan 4061 bill, it is somewhat regulated. I'm not sure the specific details, but specifically some states do have it regulated. When you look at Montana law, there's nothing in the law about Kratom. So it's just kind of sold at these dispensaries, and sometimes you'll see it at the gas stations, and it can be a pill, it can be a powder you mix in with your tea or drink. It just varies, and it's not, no one knows what the concentration necessarily, and they may list it on there, but it's not required by our laws to list the concentration. So that's why I think it's so concerning. You're not sure what dose these people are getting, and so that's what's very concerning. But I believe the Michigan law is regulated.
Thank you. Another question we had is, if meconium is sensitive for 20 weeks back of use, how sensitive is cord blood?
So just being very specific, we're not sending cord blood. We're sending a sample of the cord segment. And my understanding of the cord segment is it's as effective as meconium. It goes back a few months. So that's what makes the cord so good. And if you've ever tried to scoop meconium, which as a resident, the nurse and I are trying to collect meconium, you have to collect 2 or 3 stool samples. It's very messy. That's what makes the cord, the segment of the cord, such an easy grab. You just take it off when the placenta is delivered, collect a little sample and send it off. And so it is as good as meconium, it's my understanding.
Okay. Once a baby has been diagnosed with NAS, does the mother get some kind of assistance in how to help comfort the baby after delivery and once they are discharged home in order to help mom to maintain her sobriety?
Yes, that's a very good question. So I think it's very okay, so the first question is, we definitely work in the NICU and in the hospital with our moms. We have our nursing staff working with the mothers, how to console the baby, how to work on feeding, how to kind of swaddle them to get them to sleep, even encouraging holding them. And then we also will, show our moms, good techniques for swaddling, good techniques for soothing the baby, for working on feeding. The difficulty is once they go home, and it becomes very case specific. So, if they're a reportable, then we rely on our Department of Child and Family Services. They work hard to try to get our moms connected with support services, with treatment. in the region for the betterment of themselves and also the betterment of the child. And then we rely on them as well to make the assessment. Is it safe for the baby to go home with the mom at this time? Do they need to go in foster placement for a short while mom is getting things taken care of? Can we do a safe placement with mom with close follow-up? These are things we sort of rely on them heavily to help make those decisions. We're always trying to send babies home with the mothers and the families as long as it's safe, and that's the best practice, but it's very case by case dependent, if that makes sense.
Thank you. And then with NAS infants, is diet a concern for the mother who is planning on breastfeeding?
Oh, that's a great question. I don't know diet specifically, but I will speak to the substance use. So because marijuana is now mostly legal here, we do counsel our mothers that we want to encourage them to breastfeed, but we do want to discourage them from using marijuana because some of that gets into the breast milk. And so we do encourage them to try as best they can to stop smoking marijuana, but we'll still continue to offer the maternal breast milk to the baby. If there's things like methamphetamine, obviously being the most common, then we typically will not give that breast milk at that time to the baby because the concern is that the baby's still getting exposed to a substance we don't want them exposed to. And so, I mean, as far as diet goes, we encourage this standard diet. We want our moms to eat a well-balanced diet, stay hydrated. That's going to help them produce the best breast milk. But obviously, as a human being as well, when I say well-balanced diet, I'm not exactly probably following that myself. But we do encourage them to stop using whatever substance they were using to get into treatment so that they can use their maternal breast milk and work on breastfeeding. Does that kind of make sense?
Yes, thank you. Linda, if that didn't answer your question, you can follow up in the Q&A. So then we have another question. I have heard of weighted swaddles or blankets that can be helpful. Are these recommended for baby?
So I don't know necessarily of a weighted swaddle blanket, but we do recommend swaddlers. So you've seen these kind of like, they have sort of the angel wings on the side and the one on the bottom, and one folds in, one folds up, and the other one kind of Velcros around. And those are beneficial. They're easier to swaddle with than maybe the blanket. And so it's kind of an easy system. But I think, for safe sleep practices for back to sleep, we would discourage a weighted blanket. We typically do recommend swaddling, but I don't think necessarily, and I honestly had to look into that more, but I'm not sure about a weighted blanket. That's a good question.
Thank you. How long do substances stay in the blood or placenta after last use?
That is a great question. So a lot of it depends on the substance that's being used. As I kind of mentioned, it can be hours to sometimes a couple of days. So we have taken the approach, if a mom has used substance that the baby is at risk for NAS or NOWS, we actually will keep them in the hospital for 4 days to just keep an eye on any withdrawal-like symptoms. So it depends on the substance that they're using and how long. And like I said, it also just depends, because it doesn't necessarily correlate with, if you take a lot of a substance, a lot of it gets to the baby. It doesn't necessarily correlate one-to-one like that. So it just depends on the substance and at what point they've been using it. So like, we've had some of our mothers who stopped using towards the last few months of their pregnancy, and those babies tend to do really well, don't really show signs of withdrawal. So we definitely encourage mothers to stop using or to decrease their use in some cases of prescription opioids. If they can minimize the use, that's better for the baby. Obviously, if it's an illicit substance, if they somehow can stop, or we do see our moms who are taking methadone, and so the babies will withdraw from that, but we don't want them to stop taking that, obviously, and put them at risk for using something else as well. So it's kind of that fine balance. We rely heavily on our OBs and our maternal fetal medicine partner to sort of just raise awareness for the potential they could be going through withdrawal, and trying to find that happy balance with the least amount of medicine that does the most amount of work without upsetting the apple cart, so to speak.
Thank you. Are patients informed before the hospital that the cord will be sent for testing? Is that part of informed consent or is that not required?
In our system, it's not required. So we just send it on every baby. It's kind of our standard of care. So I think you would really have to look into state-specific laws. Is there a law that it is each state is obviously a little dependent. So you'd have to look at the Michigan state laws if that was something you were concerned about. But we don't have, we send as part of the baby's standard of care for NICU admission. So
Thank you. If meconium and part of the cord are effective, in what condition is the hair needed?
yeah, so that's a great question. I only brought it up as to be completeness of the talk. And certainly if you miss the meconium or you don't get a sample of the cord, it's thrown out, and you're really wanting to know, that's another route you can go. But I honestly have never sent a sample, hair follicle for drug testing in a newborn, but it is an option.
Is CPS always contacted for drug positive babies? And are they trained to teach foster parents how to care for NAS or now with babies?
So it depends on the CPS. We are mandated reporters, so we report them. And then we do the same thing we do with parents. If we have foster parents that are taking over, when they come to the NICU, we teach them kind of that eat, sleep, console, making sure the baby's being held if they're fussy, helping them, get to sleep, the swaddling, the low stim environment, quiet, quieter is better, making sure they're fed when they're hungry and changed. So we do that training before they go home for a couple of days or a few days if we can, longer if we know it's foster placement. And then, we have our care managers involved, our occupational and physical therapists involved, as well as our nursing staff and us as providers. And then once they discharge out, then, we're relying on the pediatricians and family practice providers, the PAs, nurse practitioners in the region, as well as child and family services to continue with that.
Thank you. We had a comment that weighted blankets are not recommended since they do not follow safe sleep guidelines.
I didn't think so. I really didn't think so. I appreciate that update. Thank you for whoever looked that up. I appreciate that.
With increase in methamphetamine use in so many communities, are there any emerging trends you're noticing?
So we haven't seen any other substances but marijuana and methamphetamine in our population. And as Trisha kind of mentioned too earlier, when you break it down by race, and unfortunately, it is higher in our American Indian population as well. We have several reservations where we have, a lot of times we have mothers present with no prenatal care. They have been using meth, and that does happen. And it's very sad to see. It seems to be higher, our numbers in the American Indian population as well. It's very unfortunate.
Have you seen any trends of worsening NAS in those with Suboxone or Subutex versus methadone versus opiates? Or is it generally the same severity you've seen?
It's generally the same severity. And so some babies are able to do kind of eat, sleep, console and do fine. And then some babies do need more proactive treatment. And so I think the important thing is to just, with these mothers that are doing the Suboxone, they're taking a substance to avoid taking a worse substance. They're dealing with their addiction, and we want to applaud them on that, encourage them on that. And we also just want to make them aware that their child may show some signs of withdrawal so that they're not kind of surprised. I think, unfortunately, there's a lot of guilt that our mothers are pressed on our mothers. I mean, having a wife who's also a mother, there's a lot of mom guilt out there. But I think a lot of our mothers feel guilty because some of the medicines they're taking to help with their addiction are affecting their baby. And so just trying to be not judgmental, to just encourage them that, hey, you know, we're going to help your baby through this difficult time. It's a short period of time. And then, you know, this is much better treating your addiction than not treating your addiction, or maybe, you know, relapsing your addiction, and that can be worse for your baby. So trying to be non-judgmental, encouraging to them, and just take it, you know, step by step and day by day with these moms as best we can.
Thank you. Where would ketamine fall, and are there higher rates of it in withdrawal with infants?
So ketamine, obviously, probably more of like the sedative category. I haven't seen any ketamine withdrawal, but certainly you want to keep an eye on these babies as they're going through withdrawal symptoms. Are they having the opposite effect? Are they more irritable, hyper alert, those kinds of things? It sort of affects the same symptoms. So you would just kind of want to keep a very close watch on these babies, making sure they're able to eat, sleep, console. I have not treated a baby. In fact, I don't think I've ever seen a mom with ketamine withdrawal, but because it's more of a sedative, I think it would fall in that sort of sedative, hypnotic type category.
It looks like that was all of our questions. Thank you so much for all those questions. They were all great ones.
Yes, thank you for everyone for attending the conference today. I appreciate it.
Thank you, Dr. Cooper. We appreciate it. There have been some questions about the slides. We will email the slides out in a post email that will be sent out with your evaluation links. And then also we will post them to the website I posted in the chat about a month after the conference. If you go out to that website, you'll see the recording out there along with the slides from the both the PowerPoints today. So thank you so much, Dr. Cooper. We appreciate you being here with us.
Thank you.
Now is the time where we're going to move into our panel presentation. So I would like to welcome Amanda Poppiti. Did I pronounce that appropriately? No, I didn't. I massacred it. How do you say that?
It's pronounced Poppiti.
Poppiti, okay. And Dawn Vernon, did I massacre yours too, Dawn?
Nope, it was fine. Thank you.
Okay, thank you so much. I'd like to welcome you both. And we're going to start out with our first question. Can you tell us a little about your recovery journey and what prompted you to pursue your path to recovery?
I guess I'll jump on in there. So first of all, my name is Amanda Poppiti. I'm a person in long-term recovery from substance use disorder and mental health. So my recovery journey has been ups and downs and all arounds and all the good things that come along with that. I started using substances when I was about 12, kind of started out with marijuana, alcohol, moved into some prescribed opiates that were prescribed for physical health issues. And then from there on, I went into more illicit substances. I was introduced to the idea of recovery in about 2008 when I had a daughter that was born substance exposed and she was experiencing withdrawal. I had already had an open CPS case, and when my daughter moved into the NICU, my CPS worker contacted me and told me that she was going to put a referral in for treatment. She put the referral in, it was only for outpatient treatment. And I found out that that level of care really wasn't appropriate for me at that time. I had been using IV substances for quite some time, and outpatient just wasn't enough. So when I tried to go to inpatient treatment, I was told that there would be a 6-month wait list. And so that was just, it was really overwhelming. I was pretty hopeless with the situation. And I was like, I'm supposed to just stop using, going to a counseling office once a week and getting random drug tests. And it wasn't enough for me. So my CPS worker and I were in communication. They were preparing to remove my children from my home. Before they could do that, I signed over temporary guardianship to a family member. And so then my CPS case was closed. The time that my children were in guardianship, my children's father and I had kind of split up. We were on and off, and that was a big part of my substance use as well. Just having him around, we were at different stages of change in our recovery. So I was able to reduce my use when he had left, changed some substances. I stopped using the IV drugs, but I was still using marijuana and I was still drinking pretty frequently. 2009, the temporary guardianship had expired, and I went back and I assumed the care for my kids. The foster parent didn't really have any issues with that. I had been doing better in her eyes because she didn't really see the marijuana and alcohol use as a problem. So right after that, I became pregnant with twins. I was able to abstain from most things during that pregnancy, but I was still using marijuana, and sometimes I was taking pain meds. After the delivery, my IV use started up again. Life was just really hectic, and it was really difficult trying to care for 4 children that were all under the age of 4 at the time. Me and my kid's dad got back together, so things were really, really toxic there too. In March of 2011, CPS came back into my life. They were called because of some domestic violence in the home and found out about the substance use. So they did a removal, and I was able to work with CPS to participate in a treatment court program, which was pretty awesome and really helpful. And I also participated in recovery housing. I did like support groups, all of that good kind of stuff. I tried some medication-assisted treatment. It didn't work for me. I didn't have enough other tools to be supported at that time. So eventually I got my children back, and I was adjusting to life as a single parent with 4 kids and trying to navigate like things. Got to be a little bit overwhelming, and I went back to my know-how thing with substances. That was my relief. But in 2014, I ended up going to a long-term residential treatment program, and I was able to take my children with me there. That was where I found my success in my recovery. I was supported. I had the tools that I needed. I had all the things that I needed to be supported through the recovery process. I eventually became employed there. I got my recovery coach certification. I started to work with women who were pregnant and had substance use disorders, which was really, really cool to be able to kind of give back. And I've been working in the treatment field pretty much ever since then. I did have a return to use for about 24 hours back in 2021. Just had a lot of stuff going on and thought I was going to escape the problems. And it took about 24 hours for me to realize that that wasn't going to be my answer. So I got back up and went back forward again. And I've been abstinent since then, working in the treatment field. I work as a co-occurring peer because I started to address some of my mental health issues as well. I found out that was really kind of playing a big role in my substance use. And I've been pretty successful since then.
Thank you, Amanda, for sharing that with us. Dawn, would you like to take some time to tell us a little bit about your recovery journey and what prompted you to pursue your path to recovery?
Absolutely. My journey has also been very long and painful, ultimately transformative. I first used substances at the age of 13. I was homeless by 14. Had experienced a little bit of any substance I could find. By 17, I made my first attempt at recovery. I had moved from where I grew up in Arizona to Michigan, and maintained a few years of good sobriety, and started kind of mingling in with some alcohol, and that started to take a hold of me. I entered college. I met my husband. I got married, mostly sober. Had 2 children. When I say mostly sober, I would use also marijuana and alcohol. Prescription medication I didn't count against me at the time, but had, used a little extra here or used a little extra there, still was very functional. About our 5-year mark of marriage, things began to kind of unravel, right? We got divorced. I ended up relapsing, and this time with cocaine. And that took over my life. I did eventually become pregnant, and my child was born cocaine positive, leading to some CPS involvement. I attempted sobriety with some meetings, some outpatient care, things like that. And it worked a little while. And when it didn't, I ended up relocating again, and this time relapsing with methamphetamines. I would change substances to try to, when things got unmanageable. So then with meth, it led me to homelessness. I met another man. We were engaged. I became pregnant again, all while using. And my third daughter was born then amphetamine positive. when she was 3 months old, my fiance passed away. In those 3 months, of course, after having my child and CPS involvement again, I was able to get sober with a little bit. I had a short-term inpatient stay. They do not allow detox for amphetamine use. So I did do like a 14-day stay and some meetings and had some resources available to me until he passed away. And then I went on another huge downward spiral. Um, Eventually I met another man and I got into recovery and we stayed sober for a while. We did really well together with meetings. That was again outpatient care, uh, and tons of meetings and resources that were available at the time. Um, but and then again relapsed and was pregnant very quickly. This time I was addicted to opiates. During my pregnancy, I did not do any prenatal care. I was quite embarrassed. I had already had 2 times of CPS involvement. Um, I avoided the doctors because I knew treatment um, was going to be their only option, and I felt I couldn't stop. So I was afraid of being offered any resources as well. When I was about 4.5, maybe 5 months pregnant, I became infected with Hep C. Became very jaundiced, and my liver and kidneys were to fail. So I had gone to the emergency room, opiate addicted, and was using intravenous street opiates as well as the prescribed opiates and whatever illicit other substances I could find if I were sick. Um, I had gotten very ill and did 31 days. I believe I stayed in the hospital trying to get my systems back on board. At that time, I had an addiction specialist at Ann Arbor Hospital try to wean me off opiates, right? Because my baby was experiencing withdrawal in intrauterine withdrawal, inside of me. So they had tapered me down to about 5 or 10 milligrams of methadone to keep my child stable for the remainder of my pregnancy. Went to a 6-month inpatient treatment place with while being pregnant and delivered while I was staying there. That daughter was drug positive and had experienced the most severe NOS or NOWS and was placed in the NICU for about 2 weeks, where she did exhibit like trouble feeding, irritability. She wasn't consolable. She needed a lot of cuddling and skin to skin contact. And I was also advised breastfeeding with the methadone that I was taking was going to be helpful. So that was a very tough thing to watch. She had probably the worst of it of any of my children. The other two did not exhibit, surprisingly, any withdrawal that they noticed. So um, losing custody again of those children, right, was the third time. And watching her struggle while she was so little was kind of my rock bottom. I thought I made a serious commitment to change, entered that treatment program, and truly dedicated myself to recovery. I did have another brief lapse for about 2 years and had while they were still in custody of foster care. And then I had decided again to do some inpatient. This time was different because I truly dedicated myself to building a life of purpose. I got out of rehab and started fighting again for custody of them, and started taking trainings through Peer 360 Recovery Alliance. I also did obtain a CCAR certification as well as a CPRC, began to facilitate meetings for other families. My passion is going to be, of course, mothers and children that have to work through the substance use disorder that we have. But then, yeah, I became very involved in the recovery community. So I had done some jails, some hospitalizations, some inpatient, some outpatient, some changing of substances, some relocating. Meetings have become a very, very important part of my life. So all of those things have helped me to sustain what's nearly 4 years of sobriety at this point. I hold like I said, the certifications and work in different organizations that support recovery and our communities. And it just fuels my passion for helping others to sustain their own recovery. Every step, though, has brought me closer to who I'm meant to be, because I do believe in the power of recovery, and I'm living proof of it. So it is possible. Thank you.
Thank you both so much for sharing your stories with us. And we have a lot of comments in the chat about thanking you for sharing your story. So you might want to read those when you get some time. Can you tell us a little about your prenatal care experience with your pregnancy? Amanda, would you like to go first again?
Sure. And I just want to say thank you guys for being willing to listen, because, you know, there was a time where mothers who use substances were very judged, and I feel like we're making a lot of progress in that area. So I appreciate being here. So I've had 3 different pregnancies in which I've used some kind of substance. Each of them was a different experience. With my first pregnancy with my son, I was honest with my doctor. I got adequate prenatal care, did everything I was supposed to do, told them that I was using marijuana and that I was prescribed an opiate for pain meds. The doctor didn't seem very concerned about any of that. They said as long as I was taking the medication as prescribed, that it should be fine. It was not a big deal. So I participated in that treatment, and it was fine. I had my baby. There were no issues. He's still fine today, never had any withdrawal or anything. My second pregnancy is the one that I struggled the most with. So that was with my daughter. I was, again, using IV substances. I was prescription medications, cocaine, anything that I could really get at the time. I didn't have any prenatal care throughout that pregnancy. I was terrified because I knew that what I was doing wasn't the right thing to do. And I was afraid of what would happen if I told somebody that I was doing this. I was afraid of the judgment mostly, I think, and the risk of losing my children. So I had no prenatal care. I remember the night that I went into labor with her, I was terrified. I wouldn't go to the hospital. Like, my grandmother actually had to come to my house and like threaten me to get me to go to the hospital because I was scared. I didn't want to go. And I waited too long to where I was like having super bad contractions and could barely walk. When I got to the hospital, my doctor didn't even make it in the room for delivery. Like, she was being born. Uh, it was a crazy kind of experience. Like, I thought I was good because I didn't hear anything from anybody until the next day. Like, nobody said anything. Nobody seemed like they were judging me. So I'm like, well, maybe she's okay. I don't know how, but maybe. And then one of the social workers came into the room and told me that they had to move her to the NICU because she was experiencing some withdrawal symptoms, or what appeared to be withdrawal. She had asked me like what I had been using. I downplayed it hugely because I didn't even want to tell the truth to begin with. So I just told the bare minimum. And they released me from the hospital. I remember going back and forth to the NICU, trying to do visits and things like that. And it was just really difficult. I felt like the care team wasn't really interested in talking to me. I felt very judged. They didn't give me very many updates. And it might have been my own shame and guilt too. It could be some of that. Like, I'm not saying the care team was terrible. But it was pretty traumatic, I think. Then my third pregnancy was with twins. So by that time, I was not using IV drugs anymore, but I was using marijuana and I was taking pain medication periodically. It wasn't an everyday thing. I don't remember any conversations or any worries about my use with the doctor. They seemed like they were fine with that. I did tell them about the marijuana use. I stopped the pain meds a few weeks before delivery because I was afraid that things would show up in the meconium. And so I was like, okay, if I just stop now, maybe I'll be okay. The twins were born happy, healthy. They were a couple weeks early, but they were decent weight for twins. Didn't have any issues, no incidents with that. And they're all actually thriving pretty great today, thankfully.
Thank you, Amanda.
Thanks, Amanda. For myself, each of my pregnancies were a very different experience as well. My daughter, who's now 14, was my cocaine positive child. At the time, they probably did not know how to identify maybe any withdrawal symptoms. She seemed a little bit more of a fussier eater, but overall, it seemed normal. Everything that I was going through, it wasn't much different from my 2 children prior that were maybe intermittent alcohol or marijuana, just rarely through those pregnancies. With my second child, who was amphetamine positive. I was intermittently getting prenatal care. They were somewhat aware that I was using. I would lie to my providers that it was prescribed ADHD medication that I was taking, when in addition to that I was using straight meth as well. So they were aware of it, and they were preemptive on helping me. But again, she didn't exhibit any like telltale signs. She was slightly smaller uh, in birth weight. All of my children were at 36 weeks. Crazy enough with 5, but she seemed to thrive fairly well. She had a lot of heartburn, nothing that would be unusual from somebody who didn't use substances, right? They could also have heartburn. So, but with my third pregnancy, I was in a really, really, really difficult place. Like Amanda, I was terrified to ask for help. I had already had so much CPS involvement, and had fought to regain my kids, and had been fighting for recovery off and on so long, that I uh, did not approach any resources. And when I did finally get care, it was just due to that hospitalization. So of course I was this extremely sickly, halfway pregnant mom with track marks and no place to live. And it was just, I was a critical acute care case that came to Ann Arbor. And so I was in a place where I didn't love myself, to even accept maybe any kindness or help. But it was later in the pregnancy that I started taking the resources, and then the treatment kind of changed when I was becoming a part of my own care. I experienced the harshest treatment. Uh, I felt like by half staff, so half of the staff could be compassionate in the hospital, that I was a mother enduring all these complications with my child, and then there were a few staff that would be, "What did you expect?" would be sometimes the comment, or um, this is what happens when you use drugs. And, clearly I knew it wasn't an appropriate behavior, and it was something I was struggling with. But the treatment was different, right? Like they wouldn't check on me quite as often, or when they did, they would sigh or roll their eyes or be rude. Yeah, so it just depended on the staff, right? You could tell some had compassion to something. I think that is something we hopefully can change. My substance use was, after leaving the hospital, it was always substance use was the first thing brought up. I was, like I said, put on mandatory methadone at the time. So every day I would go to a clinic, and their buses that took us there, and the waiting rooms there, being pregnant in a methadone clinic, even the other methadone patients were harsh, right? Like, what are you doing here? Why are you on this? And to my knowledge, it was something mandatory so that I wouldn't birth my child early. It was something that was supposed to help her. So it was really hard going to like doctor's appointments, dental appointments, pregnant, and then having to say I'm on methadone. Even though it was legal and prescribed, it was still, you were stigmatized quite a bit. So that was the hardest pregnancy overall. Eventually, when I did get birth, Covenant Hospital in Saginaw was very well versed in opioid withdrawal for babies, and as well as opioid addicted parents. So they were actually very, very kind. You could tell they were educated a little bit more. So my experience there was actually I'm very grateful for. Absolutely.
Thank you both so much for sharing that with us. So now my question is, can you tell us a little about your birthing and hospital experience with having a baby with NAS or NOWS?
So for me, my birthing experience was pretty normal. I didn't have anything that was out of the ordinary. It was pretty similar for all 3 pregnancies up until like the day after, when my daughter was having the withdrawal symptoms. But I do remember, like, during that birth experience specifically, just feeling so terrified and so ashamed and so guilty. I remember I had track marks on my arm, and I slapped a big old giant Band-Aid over it because I didn't want people to see it. So like getting my IVs and stuff, I was requesting a different place and hoping they didn't see any marks. And it was a lot of self-hatred and guilt and shame, I think, for me. It really wasn't anything with the medical staff, though. But yeah, going to the NICU was another different experience. I think, I don't know if they have just seen this a lot and they were sick of it, like putting my own, perspective on it prior to experiencing this. I had my own biases and my own thoughts about people who use drugs when they're pregnant. And I think that's what led to all of my shame and my guilt. But yeah, other than that, it was a pretty normal experience, I think, for me.
You're on mute, Kim, but I will
Oh,
go.
sorry. Yes, thank you, Amanda. How about from you, Dawn?
Wonderful. So I was very fortunate, like I said, when I was having my child at Covenant, like they were well aware of the methadone. They were use. It was a very common experience, I think, in their department. Same with the NICU. It was a very scary situation. Like you were limited how much you could be in there. But then if you weren't there, they want you to come and breastfeed and swaddle and skin to skin. And it's like a 24-hour, thing to deal with a child that's experiencing all those symptoms because they're so sick. But they did teach me how to comfort her, how to feed her, what signs to look for. It was incredibly stressful, though, because despite everything they suggested, I felt very helpless. Nothing was easing her discomfort. She was given morphine the first 3 days to help her manage her withdrawal symptoms. She had some tremors and just seemed always hungry and would take a couple sips and stop. It was hard to get her to latch. She needed constant skin to skin. Would imagine holding the child and instead of it like curling up and into your embrace, it's stretching and it's just, you can tell you can't really wrap it or hold it or care for her, like you would want to. So that was hard. And then asking for help, sometimes to the staff, like I said, some folks were very compassionate. We are where we are now, right? There's no judgment here. Let's just get this baby comforted. Other staff was just like I said, what do you expect? You did this, and not as helpful, right? They would just kind of leave the room, shaking their head, because the baby would struggle to eat full meals. She was having trouble during bowel movements. She cried a lot. If she slept, it would be maybe at an hour at a time. She is today 10, or this week, she turned 10 years old and does have some behavioral challenges, some ADHD, some trouble sitting still as well. And for that, I still carry a lot of pain because it could have been prevented or she could have been born with it, right? They don't know. The difficult part is knowing that my choices during my pregnancy played a big role and prenatal care could have probably helped a lot with that. And again, it's just fear to be honest and ask for help when you're pregnant, or talk to certain providers because we have a fear they're not going to understand and that judgment's going to take over instead of getting the factual information we need at the time, right, to help the baby. So yeah, it was really hard as a mom to want to console a baby that's struggling because I maybe put her in that position. And then also the people that knew how to care for her, right, could potentially have a terrible judgment against me for my moral choice to be in the situation. So yeah, it's tough because then at the same time you've had the baby and you're struggling to stay sober, and it's like in that back of your mind you have this voice calling out to you that you could potentially just go use again, right, and not have to worry about anything, numb it all out. So you're, as a mother, fighting that as well, right? While trying to console this helpless little human and scared of any of the resources that are available to you. So it's just kind of it's a terrible situation, but yeah, so that would have been my hardest labor for sure. And then watching them give her morphine while you're an addict yourself, it was, I don't know, that was the hardest pregnancy I think I ever had. And my last one, I will note. Thank you.
Thank you, Dawn and Amanda, for your answers. So it sounds like you both had involvement with CPS. I'm wondering if you could tell us a little about your experience and your involvement with Child Protective Services.
So I've had quite a lot of involvement with CPS. My first case started when I had just my oldest child. His father and I were about to be homeless, so we were told that if we go to DHS, they could help us get into a place. They would help, get deposit and rent for the first month. So we went there, and then we were told that we were having a case opened on us because we couldn't provide for our child's needs. And I believe I was pregnant at that time too. So I had the same caseworker, the same CPS worker for that case. And then when my daughter was born with neonatal abstinence syndrome, I think that caseworker was a newer worker. She didn't really have a lot of grasp on the resources in the community. She was nice, but there was a lack of accountability for me, I think, and a lack of communication. Like, we were living in this house for months and we had no furniture. Like, we had like nothing. We had our table that we used at, and that was pretty much it. And there weren't really any questions about that. It was like, and we were both working full time, so that was kind of odd to me. But I mean, she communicated that she was planning to do a removal ahead of time too. So I also thought maybe that wasn't the best idea because I could have took off somewhere. Like I said, I think she was a newer one. But my second CPS involvement was after my children were removed in 2011. I had a worker who was absolutely amazing. She believed in reunification. She believed in recovery. She believed in supporting me through the process. She believed in it when I did not. She was the one that encouraged me to go to treatment and to participate in family drug treatment court. She was just there. She supported me. Like, she was tough when she needed to be. She held me accountable and told me what was going to happen if I chose to continue my behavior and my use. But she also gave me the resources and support that I needed. Once I became a member of the treatment court, I was moved to another worker who was very similar, very, very caring, very kind, very supportive. I actually still talk to both of them today. And they've been a part of my journey ever since then. They're both really amazing people. So that was a really great experience. Like, you could tell that she meant reunification. And then I had another involvement with CPS a few years ago as a result of some things with my children's father and my kids. It wasn't directly toward me, but because I had custody of the kids, they had to do an investigation. And that was so traumatizing. Like, I was so terrified. I'm like, I'm not doing anything wrong, and here I am in this situation again. But I had to remember that they were there to help. I've had a lot of interactions with CPS through my work and working with other mothers. And it really depends on the worker. Sometimes you get some really great workers, and sometimes you get some that are biased and that aren't really interested in reunification. So I don't know. I just count myself blessed because I had a couple of amazing workers that got me to where I'm at today.
Thank you so much. How about your experience, Dawn?
I actually agree. I have had child protective services involved in my life, not only as a parent, but as a child growing up myself in a household that was impacted by addiction and dysfunction. My involvement as a parent began when I was pregnant with my third child. Although the CPS workers were there to do their job, I felt like there was a lack of understanding when it came to like addiction. They didn't really, at that time, the workers I had were not. It was Wayne County, and it was very overbooked, I guess I would say. They didn't have like they weren't offering any resources in a compassionate or non-judgmental way. I was kind of like a problem instead of a person. Or even worse, like a mother. Like, as a mother, I was viewed as a monster. Some workers were more understanding than others. I did have rare moments of empathy that definitely made a difference. Most of the time, if I had a positive drug screen, my children were like immediately removed. They were placed with my mother or father care, or foster care. My visits were supervised. I was always required like the random drug test. So these were like the initiations, or the interactions, I should say, with them at the time. Um, I had about 2 or 3 workers as well. So I maybe in life had a total of 10 different CPS workers. And I would say 3 of them especially really fought for me, treated me as a person, as a resource to my own care, right? They they would be able to identify reasons maybe I would relapse, or what were my barriers to getting some sobriety under my belt, and really went to bat to find the resources that would fit that, by asking questions and genuinely caring on the outcome. They would see my bond with my children was still very strong, whether I was functioning in active illness, or if I was fighting in recovery, struggling, right? Like whether it was either one, they knew I was a good mom, and they went to bat for me. I did have a worker, of course, during my third removal that was quite harsh. The one that took my last child, because when I had her in the neonatal at Covenant, the rehab facility, Holy Cross, had made a bed in the inpatient rehab for my child to come home with me. My other two were already in foster care from a prior case. And so this baby, since I had been on legal substances for the second half, and since I was doing everything told and I was in a safe environment, I thought maybe since this child, especially experiencing so much NOS and now symptoms, could come to the rehab facility with me, right? That skin to skin care, all the things that I had been learning, and it had a medical staff in there and all these things. And Covenant was on board. They were like, yes, take the baby with you, do that, in the inpatient place, and they're very close to Covenant, this center. And CPS, that particular worker had come, and she fought tooth and nail. She's like, we're taking the baby now. When my child was given to the foster care worker, I had been pumping breast milk with the methadone to help subdue some of her withdrawal symptoms. That foster care worker was dumping my milk. I didn't find out for 3 months that she had been dumping my breast milk and feeding her formula, and was unaware that the methadone could help the child right from the breast milk. And so like my worker and the foster parents at that time were very judgmental towards me, and were, thinking I was harming her worse or trying to keep her addicted or whatever it might be. So that kind of situation was really hard. Again, people were not, given the knowledge or the understanding of what all of this, how it interchanges, right? So the awareness and the educating that needs to be done is going to be so helpful. So yes, I think just like Amanda, some workers were just up to bat. Like the third time, like I said, that third removal, they said, why fight for your children if you are if you have substance use disorder, right? Why fight for your children, regain custody, when you know you're going to fail, when you know you're never going to be able to stay in sobriety, right? Because I had done it. I had shown them multiple times that I would regain my kids. I would keep recovery for about 2 years, and then again something might happen and I would relapse, and immediately they'd be involved. So that particular worker, it was very harsh because I believed her, and I went deeper and deeper into addiction, because like she said, what's the point if I'm never going to make it out, right? Why would I be a mom and risk that for my children who wanted to be with me so badly, right? And it changed, and I kept fighting, but so it just depends. You could tell which workers would look at you like you were a number, right? Like a case number, or somebody who is a moral deficit, just doesn't care about life. You're just going to use substances, right? And they would view you and treat you accordingly. And then there were other workers who would notice that you are just a human, right? You are just a human who's struggling and maybe has made some bad decisions that transferred into this long-term disease, this long-term like gnawing at you, regardless of how hard you try. So there is a difference, I think, and it definitely makes or breaks how the situation turns out. So again, it was like Amanda's, just varied, dependent on the person. My interaction with the CPS all the time. So, and then I was also very frustrated because with my third child, and the reason I asked the question about the substance use in utero, right? Because I had stopped, I think, illicit substances second trimester, and then went on to the prescribed methadone, and still the hospital considers that drug positive baby, call CPS when you're doing what you're told, and they still remove your child. Why would moms be scared to ask for help, right? When you can trust the system, which did not play out very well for me in the end on that last time. So that's something that hopefully can be looked into also. But yeah, no, that's all I got on CPS. Thank you so much.
Thank you both so much. How did you manage the emotional and physical demands of caring for your baby if and when you were able to during this time?
So for me, my baby, the one that I had the most trouble with was my daughter. When she came home, she was in the NICU for about 3 weeks. I continued to use throughout the whole time. Like, I didn't know how to stop. I didn't have the tools. Again, I was going to outpatient treatment. It wasn't what I needed. So I was actively using, but I was having this internal battle of like, I don't want to use because look what it's done to my child. And like at the same time, now I feel like crap. So I'm going to continue to use because I don't know what else to do. I don't have any other tools. So when she came home, she was only home for about 3 weeks, her and her brother. He was, I think, about 18 months at the time, and she was a newborn. Trying to care for them was incredibly difficult. I didn't get any support from the NICU. They didn't really teach me anything about caring for a baby that is experiencing these kind of things. I just knew from my own experiences of withdrawal what it must feel like. And so it was heartbreaking. It was devastating. I was often in withdrawal myself because I would try to stop using. And so I would try to muscle through as long as I could. And just, it was really difficult. I was meeting their basic needs. Like I could change a diaper here and there and do something like that, but it wasn't much more than that at the time. Also, I was still in a relationship with their father who was actively using, had no desire to stop. And it was just really difficult. I was torn. Kind of same situation when I got back with their father and had the twins, caring for them again was super stressful. And that's part of what led to me diving back in so strongly into my addiction, because I had energy then. I could be a mom that I needed to be. I could take them and do things and play and be here and present with them. I couldn't do that when I was going through withdrawal. And I felt like even after a period of time, I had some time in there where I wasn't feeling withdrawal, but I still just had no energy and I had no like drive for life. So for me, those substances were kind of a lifeline. I felt like they were a lifeline at the time. So that's how I got through it.
Thank you, Amanda. Dawn?
Caring for my newborn with NOS or NOS was a really difficult time. It was overwhelming. She needed so much more attention than a typical newborn. She couldn't seem, like I said, to get comfortable. She could barely sleep for more than a few hours. She was struggling to gain weight. She cried often and was really hard to soothe. I did breastfeed her when I got visitation 3 times a week, right after the first initial 2 weeks. Of care, and she was then released from NICU to foster care. I would get her 3 times a week, and I would breastfeed, not knowing that she was having the rest of it dumped out, right? But it was just definitely really, really hard. Around 6 months of age, to kind of settle and become more consolable. I want to say, like in the NICU, just again, I'm just so grateful, like to Holy Cross and Covenant, because they worked hand in hand so I could be there for my child who was struggling so hard. So I was an inpatient with Holy Cross, and I would have to stay inpatient. I would have to do my classes from 8 to 4. And then from 4 p.m. to 8 in the morning, I would be then transferred by bus to Covenant Hospital to sit in the NICU with my daughter and be able to console her and be there and hopefully create this bond of healing together. So it was really, I was very lucky, but not all mothers would have that, right? Kind of situation. So yeah, it is definitely tough. And it seems like, you know, you need two of you to console a baby with NAS, because like you're mad at yourself because you feel so to blame, right? That it's really hard to get that connection and bond, right? Because you feel like you've already hurt this child. The guilt and the shame you have, right, is very different from the maternal feeling of having this healthy, beautiful baby you've grown. Now you have this like consolable, unhappy baby that you're trying to bond with that you've also hurt. And so it's just like psychosocially hard alone, not to mention the outside, everything else, right? The judgment you're getting when you go to like your 2 week well visit and they're like, telling you all the things that you could have done better, or whatnot. I don't know. It is difficult, and definitely some support at that time would be amazing for parents to have some kind of like productive training on that aspect as well. Like not only just like how to console your baby, but like how to relieve your own self of guilt and shame to be a better mom. How do you pour from an empty cup, right? When you're in that spot is all.
Thank
That's
you,
all.
Dawn.
Thanks. Absolutely.
What was the most challenging part of caring for a baby with NAS in the first few weeks or months, if and when you were able to?
So for me, the hardest part was the guilt and shame, the lack of support, and the lack of education on what to do. So again, I was with my children's father. He was pretty abusive. He didn't have any desire to help with the kids or to stop using. But I felt stuck in that relationship, didn't have a lot of options to get out. My mom lived out of state and wasn't around. She was usually pretty supportive when she was here, but she had been gone for a little while. And my dad had no grasp on how to deal with anybody with a substance use disorder. He would just tell me, well, why don't you just stop? Like, why do you keep doing this? Like, he didn't get it. He was supportive in other ways, but that was like my own internal battle as well. Like, why can't I just stop? So really just feeling alone and not having a lot of skills and a lot of support for me.
Thank you. How about for you, Dawn?
The most challenging part, I think, was like only being able to care for my baby for those first 2 weeks. Like I said, uh, the few and far between people I had of support were not allowed there, right? You can come back and expose other babies potentially. So like there was no family visitors and things when I was there. Having to leave her at the NICU and go to treatment to stay focused on recovery, right? To leave her to go to inpatient from 8 to 4 was hard each and every day. And then even harder was, like I said, they told me the hospital as well as the inpatient facility was like, yes, bring the baby. They built a nursery in my inpatient rehab for the baby. And then CPS, of course, stepping in and saying no. And the hospital's like, it's for the best interest of the baby. She's suffering from NAS and all these things did not matter. So that was really tough too, to have to say goodbye. And then I had stayed in inpatient care to wean off the methadone, which they do very slowly when you do it the right way to get a completion certificate. You could go up quite a bit in milligrams, but you cannot come down as fast, right? So that was a struggle because then I would want to be off of that before I left my inpatient stay. But so all of those things were going on, which made it really difficult to care for my child. And then of course with her being removed and only seeing her every 3 weeks, was really hard. And then the foster care worker, of course, would say, "Oh, she's still, she's really messed up," and comments of that nature because she would be up with my poor child, right, who's not sleeping, who has to be fed. This foster mother is caring, which I'm grateful, obviously. But to hear it, right, when you're wanting to do it, I want to do it. I want to take care of her. I did this to her, and so that was also hard. So those were the toughest things I think for me, and watching her, just like I said, not being able to help when you're the mom. This is my job. I'm going to make you feel better, and not being able to, right? Not being able to at all, and not liking myself while I'm doing it. It can be hard. That's for sure.
Thank you both so much. How can providers better support individuals who have babies born with NAS and NOWS?
I think first, just treating us as human beings, like we have substance use disorder. It is an illness. It can be treated. We're not just awful people. Getting to know our stories and interacting with us, teaching, like for me, if somebody would have taken the time to sit with me and teach me about like, how do I care for her when she's having all of these things happening? Having the resources and support. I think having peers who have lived experience in our settings, in our hospitals, in our doctor's offices, people who have had some similar experiences that can kind of help reduce the stigma and help us feel less judged. I think that's pretty powerful too. Because I know for a lot of my life, I haven't been able to understand how a parent couldn't stop using for their child. Like that was part of what led to my own use. My parent couldn't stop using when I was a child and they left. And I was like, how can that happen? Until I was that parent and I couldn't stop using for my child. And I had a funny way of like getting to understand real quick. But I think, yeah, having peers, I think, is really powerful. And then having places like this where you are willing to listen, and everybody's been so encouraging and supportive. I was terrified to come in here and talk about this stuff, but everybody's been awesome. I appreciate it very much.
Thank you, Amanda. And how about for you, Dawn?
I first want to agree with a lot of what Amanda said, because it is just simply being like human. Like, imagine if you were to walk into a cafe and your friend's like, this coffee's really great, try this coffee, and then you try it, and then you try it next Sunday, and then by like the following week, all of a sudden you need that coffee, right? Like and then you're addicted, or you're stuck in this cycle of active illness. I don't know. But it's just based off a human and getting in this situation. So like having that understanding that sometimes a person's not purposefully damaging themselves anymore, but providers could offer probably much better care if they receive training to like what we do, at least as peer coaches, some motivational interviewing, maybe how to ask that parent where they're at, meet them where they're at, and have an understanding of where their baseline of resources is, or what needs they still have to, right? Like if you're going to go home and care for a child, if providers in the hospital were set up to help with that, like identifying barriers and resources, because we don't know what we want when we're in active illness. We don't know what we need. I don't know what my favorite color is or what my favorite food is. It's you're in that kind of state where those are hard to draw out. So having the training that we received as peer coaches, I think, definitely could help providers in offices that deal with people with substance use disorder. That would be super helpful. Most people who are actively using don't do so by choice. Like I said, I wrote some things down, so if I'm bouncing, I apologize. But approaching patients with this context in mind, that we were somebody's little girl once, right? Like there was a time we were just like everyone else, and see us as a partner in our own care, maybe, right? Because some of us are going to need different things. Instead of us just being a problem to fix, right? Or I feel maybe a provider might say, oh, well, this person's kid's getting taken anyways. I'm just going to call CPS and they're going to, leave, and like the resources stop as soon as foster care is called as well, right? Like, so once the child's removed, you might have to drug test or whatnot. But I didn't at that time have like counselors come in and try to help me for losing my child to the system, or I don't know. So some of those things I think would be helpful in this situation. An understanding of substance use disorder or addiction, and as well as recovery, right? What kind of pathways are there out there? Like some providers might not know that methadone might be useful for some, and like they might not know that 12 steps won't work for everyone. They might not know the difference in withdrawal, right, of different substances and what that parent's going through. So just education, I think, and like we're doing here, right, having open communication, exposing it as not a stigmatized moral deficit, but just of something that's going on in society that we can all work together to address, and treat each other as resources through it. I think that's ultimately what's going to be helpful overall.
You're on mute.
You're on mute.
You're on mute.
Thank you. What supports and resources were most helpful to you during your pregnancy and postpartum?
So for me, during my pregnancy, I didn't have a ton of resources or support, but postpartum, I think for me, CPS was one of the most helpful things. They provided the accountability and the connection to other supports. My family drug treatment court program was amazing. They had some structure set up for me and some expectations. They connected me to counseling. I don't know. I've just been fortunate to have gotten some really great workers who believe in recovery and in reunification. They helped me remove a lot of the barriers that I was experiencing. I remember like being in a position where I could get my children back if I had a place to live, but I couldn't get funded for a place to live until I had children in my care. And I had a whole team of people backing me, like behind me, and they made it work. I don't know what exactly they did to make that happen, but they did. They placed a couple of my kids back with me first so that I had some, and it wasn't a super big, overwhelming, like crazy experience. And then I was eligible for some other things. I had a DHS worker that was able to make it work to where I could get some cash assistance because I was so involved in treatment. There wasn't a whole lot of time for like having a job. I was trying to figure out how to learn without the use of substances, and then how to be a parent sober. So it was a lot of things. Yeah, I think that's for me, helping remove those barriers. CPS was the biggest one for me.
Or mute
There she
again,
is.
Kim.
Thank you. Thanks, Amanda. I think same thing. CPS was kind of a double-edged sword. There was things that were bad and there was things that were good. I did like that there were partner agencies. So in my case, like when CPS did step in or were helping me with the aftercare and things of the children, and like Holy Cross Services, Wellsprings Lutheran, Adoption Options, Families First, any kind of resource that was out there, I asked for. And a lot of times CPS might not have even been knowledgeable of them. But I had done research, right? Like who's going to help me maybe get to an outpatient drug class when I don't have a car, or Section 8, I was luckily able to get, or food stamps or WIC and those things, right? Because I already had all these other things like impeding on me that I felt like I couldn't do. So having those kind of like community resources available definitely helped. I think one of the biggest things that's helpful though, through all the agencies and such, is like recognizing the wins. Encouraging the mother, right? Even because you've got to figure if you're trying to counterproduct like the shame and the guilt and all that, it's got to be like you have to find pride in yourself and worthiness, right? To keep going. I think like if I had if I tested dirty for 6 substances this week, and then like 2 weeks later, I had been tested only dirty for 2, right? Let's just say that was a situation and my worker recognized that. Like instead of saying, damn, you're still dirty for 2 substances, right? They would say, Dawn, you're down to 2 substances out of 6. I'm most likely going to call her and go back to see her or be helpful in conversing with her because of that, right? Whereas if the worker were like, listen, you're still not, you're not sober, then that's very discouraging. And that feeling is just going to drive me to want to use again, right? So whether it was CPS or whether it was the doctor or whether whatever resources out there, it's crazy how that little bit of just good job or attaboy, and it seems crazy, but I mean, it was definitely what would prompt me to continue. It gave me hope that I could become normal, or I could become, successful in my recovery that way. So that's always nice to throw out there. I think that helped a lot.
Thank you both so much. How have you approached recovery or treatment since giving birth, and what resources have been most helpful to you in that aspect?
So for me, I've had to change like my mindset about recovery, what recovery looks like. It's not necessarily an abstinence from all substances. It's not necessarily going to a 12-step meeting. It's not always just going to treatment. There's medications that work great for recovery. There's other kinds of support groups. For me, like church has been a really big strength for me, like having a belief in a higher power and having a purpose. Being able to give back and use some of my story or some of, all the pain and struggles for something positive is like a redemption kind of thing. Being in a room like this and being able to share my story, and I didn't cry yet today, so that's pretty cool because it was tough writing out some of the answers to these questions. It's been empowering, and I think again, yeah, being able to use all of that pain to help somebody else who's struggling, letting them know that they're not alone, that they're not just some bad person because they've made choices that didn't turn out great. So I don't know, my recovery today is like my life. So it's been like all of it, everything that I do today, my recovery comes first. I have to incorporate that into how I care for my kids, how I care for my family, how I am in relationships. Like I'm recovering from a lot more than substance use. And it's just so much more. Like I said, taking care of my mental health was huge for me to be able to sustain some recovery and to be the best that I can be. I feel like I'm doing that today, and it's a pretty cool thing.
Congratulations and thank you. And how about for you, Dawn? how have you approached recovery or treatment since giving birth, and what resources have been most helpful to you?
Absolutely. Thank you. For me growing up, recovery wasn't a big deal because it was kind of normal to maybe be derelict and to have everyone in your family on active illness, right? On something or another. It was normal. So like, my perspective on recovery originally was it was impossible. It was this dream that people wanted you to believe, and that it wasn't necessarily like a way of life. What changed that perspective for me, I think a lot had to do with and ultimately saving my life was some of the training and support I received from Peer 360 Recovery Alliance. It's just phenomenal the way that I look at my own disease in a different way because of some of the things we've been taught through them. Also, NPHHS with their trainings and certifications has been very helpful. I learned to be patient, accountable, live with integrity, regardless of the mistakes I made in the past, right? That I was a brand new person if I wanted to be, and I was encouraged along the way because of that. It's also been my passion to reach out and help others as well, right? Because if they are like me and they are assumed to never change, then what support is going to be given to those folks? So I want to reach my hand back in the fire and pull them out, especially mothers or parents, and that goes both ways. Dads struggle just the same. My passion is also that I have 5 children that I would hate to see in any of the situations that I was in. I don't ever want to find my daughter with a needle in her arm and in a abandoned house, right? Like I don't want to have my child not know how to be honest about struggling with the wanting to use or something in the future. So my passion for this is to break generational curses, right? And to end some stigma so that people who struggle can find their way out. And like Amanda said, it was a nice perspective also learning that it's not cut and dry. There isn't a book like that's going to work for every single person. And it's not dependent on just the substance or dependent on the class or the race or the age of these people. It's entirely everyone's journey can be so different. Whereas Suboxone might work for one and not work for another, or 12-step meetings work great for some and maybe not, right? There's so many options luckily out there now that helping folks find their right pathway so they can be more successful is ultimately what prompts me to continue in recovery and stay well rooted in the community that's helping it grow.
Thank you so much, both of you. What advice would you give to someone who is supporting a person who is going through a similar birthing situation as yours? So someone who is in active illness and having a child.
I think the biggest thing is to let them know that they have options, let them know that they're not alone, give them a safe space to where they can be honest and open, helping them get connected with a peer. Again, I think peers are powerful. They have a lot of, I can't think of the word I'm looking for, relatability maybe, that kind of helps break that stigma, help them find what's important to them, because that's different for all of us. Like for me, that was the one thing, being a mother was the one thing that was valuable enough to help me to stop using substances. But it took time, and giving them tools, helping them find the right tools, getting them connected with other people in recovery who've walked that road. That's empowering. It offers a lot of hope. I know we didn't have peers when I was coming into recovery. It wasn't really a thing, but I had a couple people in my life who had made it through their active illness and they were doing pretty well. So just being able to talk to them let me know that this is a possibility. It's not hopeless. We can get better. This illness is treatable, and it's not a straight line path. Like there's ups and downs and backsliding, and like every return to use isn't a failure. That's just part of their learning process. It took me a long time. I had 7 years of abstinence and had a return to use, and that was pretty hurtful for me. I didn't understand what was wrong with me. Why didn't I have enough tools? I have an illness, and if I don't continue to treat my illness and find new ways to treat it, because sometimes the old ways don't work, then I don't get better. So again, just accountability, kindness. Accountability is huge too. Like you can support the person and not enable the person, right? You don't have to give them all the things that they're asking for. You can help them find their own strengths, help them get their own things. Accountability was huge for me.
Thank you so much. How about for you, Dawn?
Thanks, Amanda, and everyone. Definitely being kind, remembering it's a person first and foremost, someone who's likely been through a lot just to get to this point. They're now responsible for caring for two lives, right? And possibly struggling to take care of their own. Fear, shame, lack of support are heavy parts of the equation. What they need most is someone who can meet them with patience, compassion, willingness to listen without judgment. We in that moment, a pregnant mother with substance use disorder, does not know what we want or need ourselves, maybe most times, let alone to prepare a new life entering the world. And gentle guidance from someone who understands makes all the difference. So I agree with Amanda, like a peer coach, perhaps, or someone. It's easier to learn from somebody who's been through it, right? You see someone who has overcome active illness and is now like doing well, and they're not going to view you as a person, a failure of a person, right? You can learn from them that way. I don't know why that works so well, but I agree. I think that peer-to-peer support, maybe some group meetings, like if parents were able to meet together and talk about how hard it is to stop when you have this baby in you. Like I couldn't stop for me. What makes you think I could stop for a baby, right? Like yeah, I agree with her. I definitely think some peer coaching in hospitals or birthing centers or something like that, someone who's experienced it would be super helpful, because it is ever changing. It is like Amanda said, one thing's going to work for maybe a couple weeks, and all of a sudden that thing is not helping you stay in recovery anymore. So having someone who's lived through it and has education on all the different pathways that could be accessible to that parent is going to ultimately be like the save all for sure.
Thank you so much. So can you each talk to us about your experience with healthcare providers or other providers while in active illness and early in recovery? What helped you? What hurt you while seeing those providers?
My interactions with healthcare providers when I was in active illness, it was few and far between. I would avoid those places for the most part because I would feel very judged. I feel like the stigma was still pretty harsh. It's been some years now, so it's gotten much better, and I'm grateful for that. But we didn't talk about substance use. We didn't talk about warning signs where it could start to become a problem before it gets too crazy. It was always like this idea of just say no, and that's not real life. Like it wasn't my real life anyways. I didn't have the ability to just say no. And I started my opiate use with a prescription medication that was legal, that was given to me for pain management, for legit pain management. Sometimes I still find it difficult talking to healthcare providers about substance use because then I feel like I automatically have a label. And so if I have something wrong with me, and this is probably my own stuff, but I feel like they're like, well, you're just seeking X, Y, and Z, and that's not the case because I don't use any substances today. So there was a lot of hurtful interactions, and I think today people are becoming more educated. They're willing to talk about it. Like my doctor today, he talks to me about it. He gave me a drug test recently, and it was great because like I was negative for everything, so that was awesome. I don't know, just reducing the stigma. My interactions have changed a lot, and I'm usually a pretty open book with most providers because I feel it's like my duty to advocate and to show like this was my story. This is not my story anymore. This is who I am today. And helping them get some hope, because I know just from working in the treatment field and working with people in active illness, it can get really heavy and can get really hard, and it can seem really hopeless sometimes. And burnout's a real thing. So like all of that impacts how we interact with the people that we serve. So I again try to be a hope, like some kind of hope to instill with the people that I work with the people that provide services to me today. Just providing a different perspective.
Thank you so much. And how about for you, Dawn? What helped? What hurt with you dealing with providers?
Very similar to Amanda. There was a lot of times that just did not go. Maybe my fear of how I would be treated um, would keep me from going because of those few and far between those instances, like I mentioned before. So when they had made comments like, "Why do you do this to yourself?" or "Why can't you just stop?" or "Oh my gosh, your screen came back positive again." Like those little comments were unhelpful. Um, some doctors seem to question the point of helping someone that they believe was going to self-destruct anyways. This response only kind of deepened like negative emotions I was already going through. And there was a time I didn't care if I lived or died, right? Like I had hoped it would just end. And so shaming me was more harmful than anything. Um, like the motivational interviewing, asking a person like, "How are you today?" Right? Just genuine, like, "How can I help?" Treating it like a person um, without the sidebar comments, I guess, was helpful with the providers that I felt cared, right? They without saying like what had already happened. It was like, "This is what's going on. Your child might come out with some NOS. This is how we're going to approach it. What can I do to make you more comfortable while you are getting ready to birth this child, knowing there might be something wrong?" I had some folks that just had genuine conversation with me, just treated me like a person and also a resource to my own care. And then I felt like I was part of it, the plan, right? There was no naysaying on why I was there. There's no questioning why I can't stop. There was nothing, I wasn't dwelling on the negatives, I guess, so to speak, with those healthcare providers. So it made it super helpful. Some of them offered like non-addictive medications to provide relief and alternate ways to cope, and would ask my feedback. Right? They weren't just treat. It's like the dynamic is different if you're being treated like you're a resource to your own care, right? Rather than being told this is what you did and this is why it's happening, or this is what you should do, or that kind of like standing over you, looking down at you type situation is not helpful. So any of the healthcare professionals that I worked with that would make a difference, or I felt like were productive, were genuinely meeting me peer to peer level to discuss what we were going to do about whatever situation would arise. That felt safe, and that felt like um, I could be more open without judgment, and then therefore get to a better way of caring for us, myself and the baby.
Thank you so much, both of you. So now is the time where we open it up for questions and answers, and we have had a lot come in since we've been talking. So I'm going to start out with the ones in the question and answer category. And the first question is, where was the long-term residential program that included children? And I think that was yours, Amanda.
Yeah, so the one I went to was the Saginaw Odyssey House. I also went to Holy Cross at one point too, and they allowed children, but it was only up to like 5 years old. I think they couldn't take school-age children. The Odyssey House, I had all my children who were all in school. We went in with pretty much nothing. They got school clothes and supplies for my kids. They made sure that we were comfortable, helped us get back and forth to appointments. It was really kind of cool. They had some groups and things for the kids as well. So yeah, it was at the Odyssey House in Saginaw.
Thank you. Another question, do you feel supported by professional peers when you discuss feelings of burnout, or prevent yourself from discussing it out of fear that they might think that you might be struggling with a relapse? I'm very proud of you both and glad to call you colleagues.
I personally have not. In the RCOs that I've worked with or contracted with, they are super, super adamant that if you need a mental health day, you take it, right? If you need self-care, we will help you get self-care. It's a big, important thing to be like fill from an empty cup. They know about burnout. So I haven't experienced any of that in my profession. They've been very helpful. So I personally, I haven't had any accusations of relapse, because that would be non-productive. I think um, just how are you, right? How are you? What do you need? Do you need a day off? Maybe you should take a day to pamper yourself. Self-care is encouraged.
Thank you. How about for you, Amanda?
Yeah, I've had a pretty similar experience, especially with other peers who have kind of been through it and get it. I know once upon a time in my early days in treatment, it was a little bit harder to talk about when I was struggling or when I might need some extra time because there was always that fear of they're going to think I'm going to relapse as soon as I talk about something. But these days, it's very, very supportive and very focused on self-care. And I think that's really cool.
Thank you both. Do either of you have tips for navigating that with other struggling moms? Mostly asking due to our roles as mandated reporters, but not wanting people to feel judged.
So I know when I was working in the program with pregnant mothers, the biggest thing was being transparent, letting them know, like, yes, I am a mandated reporter. These are the things that could happen. And then just being honest, being open, do what you say you're going to do, follow through, and being really mindful of your own biases and body language and facial expressions and tone. All of those kind of things speak a message that our words don't necessarily say.
I'd like to say I agree with her. Absolutely. Like stigma can come in words, it can come in looks, it can come in body language, right? Like there were times folks would move away, right? Like just like the way they even sit, just like I'm contagious, you're gonna catch these kind of, substance use disorder, run. So I agree with her on that. And then yeah, no, that's probably pretty good on that. Helping moms that are dealing with it and letting them know you're going to be being open and honest with them first, right? You're not expecting them to be honest with you back if you don't say, hey, I'm a mandated reporter. If this should come up, these are what we will do to, further help you resource that problem, right? There's nothing you can change from today, but being honest is how I can help find you those resources that you need and eliminate the barriers you're going to face because of the choice you've already made. Let me help you. You're right. That would be how I would maybe approach that.
Yeah, I've actually been in a situation where I had to make a CPS call and we invited the parent to make that call with us so that everything that was said, they were aware of, there was nothing done behind their back. And then again, I share my own experience with CPS and how it can be a great resource.
Thank you both. What is your biggest piece of advice for therapists or case managers when working with a parent that is actively going through withdrawal and still having to parent or still having to work on their sobriety or harm reduction while pregnant?
I believe educating themselves as a therapist on like local resources that are available. Some counties still struggle with having things that would be helpful. They might not have detox facilities. They might not have outpatient care. They might not have CMH that's open for like 10 months. So just sitting with them and meeting them where they're at, I think is always helpful and finding them a peer that has gone through that, right? That has been successful in overcoming that, sitting with them at the same level, right? And holding their hand, so to speak, while they decide what's good for themselves. Right. We don't ever want to tell them do this or do that. We can only encourage them to agree with us at the same time. This is going to be helpful, right? And then maybe encourage it in that way, if that makes sense.
Yeah, I agree with Dawn, finding the resources that are available, knowing the resources, checking on them every so often because they change and things, evolve, but also focus on harm reduction as a recovery pathway. So there are things that we can do to stay safer, making sure that they have some support to protect their child. Yeah, harm reduction is huge, and we don't talk about that a lot, but that's a really important thing to do. Like the medication-assisted recovery is part of harm reduction, but so is using 2 substances instead of 6, like Dawn was saying.
Thank you both. During your recovery, did you have home visitor? I'm assuming a home visiting program. If yes, what was your reaction or impression about that? How did the home visitor make you feel? Any advice about home visits?
I did have a couple, and again, it was my impression was different. I guess that they came in, started spouting out what I had to do or why they were there, or fill this paperwork out, right? Where I felt more of a recipient than a resource or a peer, then the dynamics would change. When I had home care workers that would come and and ask me just to meet me where I'm at, to talk to them like in that way. And what would you like to do to get to, like our parenting classes, for example, they might offer, right? Which ones have you done before? Which would you like to learn? Where are your strengths and weaknesses? When they came at me, that attitude was a little different. There were other times like these people would come and, fill this out, tell me this. You're going to have to do this by next week. And that I don't know why it didn't seem as helpful. But it was just the body language, how they talk to you, how they sit with you, how they interact, right? If you're treated human and they're looking at you like you're a human, and they're warm and like how you sit and eye contact and things makes all the difference, I think.
Yeah, I agree completely. I know that a lot of my homeworkers would come with a lot of resources, and at the time I didn't have a lot of things, so that was like the carrot for me to want to meet with them, is like there was a benefit there. I could immediately see what would help in this meeting. So that was cool.
Thank you. I'm having a hard time getting these moms to even let me in. Do you have any advice?
I'm with Amanda. If a worker showed up and it was 3 months to Christmas, then they're like, hey, I can get you signed up for Toys for Tots. Maybe we can help find you a free bed for the children. Hey, let's go to the grocery store. We've got a $25 voucher for groceries, right? Them coming with a resource idea or a resource in mind made me think they were there to help, so I think that initiating it, right? Finding out what that person needs, hey, can I come in? Or, hey, what are you going through? What can I help you with? How can I help? Right. Like that initial statement right away would make me comfortable to open the door. Well, hey, I need gas money. I need a ride to this job interview. There's we're going to always need something when we're in that place, right? There's so much lacking that is a good way to get something going to start it out, right? Um, maybe I didn't even know Christmas was coming in 3 months, kind of thing. So
Yeah, I think it's really important. I work with a lot of people in multiple stages of change. So like understanding where that person's at in their stage of change and what kind of interventions can help. So like if a person is in pre-contemplation, they don't think they have a problem, helping them, just having some conversation like, okay, so why do you think that this is working well? Or what about your substance use is causing you problems? Maybe if you think it's stupid that you have CPS involvement, well, what are some things that we can do to keep them out of your life? And letting the power go to the person and letting them come up with their own solutions instead of providing all of the answers it's empowering to them, and they have more buy-in, so they're more likely to follow through with the things that you guys come up with. And being human, like being down to earth, being human, like the people that used to come see me when they were like down to earth, I could talk to them. Maybe sometimes they'd share just a little bit about themselves so that I could see that they're not perfect either. Like I had a CPS worker came once that didn't have socks on that day. I don't know, she forgot, she was in a hurry, something happened, but she shared that with me. And I was like, okay, that's a pretty human thing to do. It kind of helped reduce those barriers and take the walls down.
Okay. Amanda, you mentioned about starting using substances since you were 12 years old. What was the reason or causes? Was it related to your upbringing or environment or peer pressure? Any reason that led you to that?
All of the above. Yes. So I had parents that were people who use substances. It was just pretty normal in our lives. Friends, I struggle again with some mental health issues, some pretty severe anxiety and depression, things like that. And so I was self-medicating for a lot of the time too. Kind of helped me socialize with other people. And it was just normal. Like it was things that the people around me were doing. So that's what we did.
When resources were being offered, was home visiting services shared as one of the services available to support you and your infant? If so, what influenced your decision to accept or decline the services?
I know for me, it was mandatory to get my children back that I would have to participate with home visits. It was a part of like the checklist that the courts would need done before I would be allowed my children back. So in my case, that's how that went.
Yeah, it was exactly the same for me. I didn't have an optional home visitor. I guess it was optional, but if I chose not to, then I wouldn't be able to get my children back. So to me, it wasn't optional.
How long have you been in recovery now, Dawn?
I will be.
Oops, I'm so sorry that you went through so many cycles. You are a very strong person.
Awesome. I appreciate that. My sustained recovery this time is nearing. So in June, I'll be 4 years in sustained recovery.
Thank you both for helping to make change so we can all start or continue to see people as the human beings they are. Your lived experiences give many insight that they might not get in other ways. To join this field with so much trauma attached to it is very inspiring. Thank you both for sharing your stories. These are powerful to both advocate and educate. You should be proud of the work you're doing. Amanda and Dawn, you are incredible. Thank you for being so vulnerable and open about your lifelong fight to get clean. Every single mother matters and every single child matters. Your bravery does not go unnoticed, and I hope your journeys will help others because of your bravery and endless fight for sobriety. This world needs more Amandas and Dawns. Oh my gosh, this is why families lose faith in the system. Thank you for fighting for your family and sharing. Has there been any long-term effects to your children that were born exposed? What age did you start to see it, and did it ever decrease or get better?
For mine, there's not any like physical or mental health issues directly related to the substance use that we know of, but a lot of lifestyle things that come along with substance use expose them to a lot of trauma and a lot of things that they are now having to work through, as mine are all teenagers now. So that brings a whole like bag of guilt and shame back again, but trying to empower them and help them find the tools that they need so that they don't go down the same road as mom did. And they're very aware of substance use issues and tools to prevent it and all of that good stuff.
I would like to, yeah, concur for sure. For mine, my daughter has pretty moderate ADHD. But again, like her physician said, it could just be that she has ADHD. I was diagnosed as well, so it could be genetical, and it could, or I'm sorry, genetic, and it could be because of exposure. They don't know. Right. They don't know. And for my situation, like the one was cocaine positive, one was amphetamine positive, one was opiate positive. Out of all of them, I think I've had more behavioral struggles with the opiate positive, which was my only prescribed substance that she was positive. Right. And then, but environmentally, right? They remember being removed by CPS. They remember mom sick or ill or withdrawals or what they've had, so the trauma that they've endured could have a big part to play on how they act or interact anymore. Not feeling safe and the trauma that causes our children. But like Amanda, right? I involve my children very much in the recovery events and community, and so that they're well educated as well, and that they hopefully have tools to prevent themselves from being curious, from following in our footsteps. And if they do follow in our footsteps, because they might be 5 times more likely right than other children, that they also know what to do right to help themselves get out. So that's very, very important, I think, in the fact that they've witnessed 5 or 6 different versions of mom, and so that's my biggest, I think, with the substance use, that's the biggest concern I have, at least for all my children. Wasn't anything inherited by my use. I think it was the environmental trauma. for sure as well.
Thank you both so much. If you could make 2 recommendations for changes with substance use disorder mothers in pregnancy for the state of Michigan, what would those be? And do you have any suggestions for specific professional agencies that you both worked with for many years within your substance use disorder maternal journey?
So that's a lot to think about. I don't know. I think, again, incorporating peers into more places, mandating having peers in like the obstetrician office, all of that kind of thing, to be there to have those conversations, I think would be fantastic if they were funded for those kind of things. Yeah, I don't know. I gotta give that one more thought, I think.
I like the question. I think some of the things that could definitely help is like for a struggling mother who's like Amanda and I, we might have been afraid to do prenatal care, right? Because of judgment. So like just having some kind of safety, given some safety, right? Like there might be a clinic that accepts mothers that struggle with addiction, right? Or substance use disorder or active illness. They could come there without being automatically mandated. I don't know. I don't know how that would play out, right? I believe mandated reporting is also important, but maybe, with that comes resources offered, so that someone could feel safe to be open and honest. I think that makes all the difference, right? Um, yeah, and the peers and being in place, it's the only thing that has helped me and encourages me and gives me hope is this amazing community of peers that I see always educating and learning. So I think just like she said, if there were placed in more places, people would feel the ability to be accountable and open and honest. And then we could identify, right, the needs as they go and be able to resource broke from there. Someone being comfortable to come into a doctor's office and be like, hey, I just shot a bunch of heroin on my way in. And yes, I'm 7 months pregnant without judgment is going to be hard. Having maybe a coach in an office or a trained professional, right, that has come from using as well. I don't know why that makes a difference, but it does. I think that would be helpful. People would come in and be open. Like, listen, I'm dope sick and I don't want to be here. I can tell a doctor that without feeling like they're going to call the police in 10 seconds or that I'm going to be arrested on my way out. That comfortability that I'm going to leave that day, or that at least someone's going to say, that really sucks. I'm sorry you have to feel dope sick today. Good job on trying to be recovering. Let's get you some resources on your way out, but let's do your weight and height and go on with the day. It would run smoother. I guess, I don't know. I kind of agree with you. Just having a safe feeling like you're able to be safe would be one main thing, right? Like if you can, like if your friend overdoses and you call somebody for assistance, you're not going to get arrested. Like an angel program for that, right? Situation. A doctor's office too. Like we know if I used up until my 2nd month, just found out I was pregnant, I know my placenta is going to be substance positive and my child's going to get removed. I'm not coming to the doctor right away because I'm already scared that this new life in me is already going to be taken. And so having, yeah, just feeling safe to be open and honest and ask for help.
Yeah, and we need more treatment options, more things that are low barrier, where you don't have to do all of these things, or I don't know, where we can meet people where they're at, and like places where women can bring their children, or parents can bring their children, fathers too, because fathers have kids that they're caring for sometimes as well. We just need more resources, more mat availability. Like it'd be great if like doctors could all prescribe that. Like that way you don't have to go like across town. I know where I'm at now is a very rural place, and the mat options are few and far between. So having more options.
I want to point out too, a lot of detox or inpatient facilities are scared to take an impregnated woman because of liability, right? Their insurance could, if something were to happen to a pregnant mother, then their insurance might not allow them to treat a mom who's pregnant. So like as a pregnant parent, if even when you are ready and you have been able to open up to a doctor or find a resource, right? It's like Amanda said, so far and few between. Like, hey, there's rehabs everywhere, but they just won't take you because you're pregnant. Or imagine being pregnant and then also needing MAT or being on prescribed methadone or Suboxone while pregnant, that's a whole nother liability, right? Oh, you can't come here because you're on a substance. Some rehabs might view it as illicit, and some might not. And so the options being available is just, it's crazy.
Thank you both so much. There are a lot of comments in here about congratulations and how great your story has been. Do you feel like your fight to help others understand your traumatic journey will ever end? Example, people understanding you didn't choose this path over and over. Current behavioral or mental health concerns with kids stemming from past use, etc.
I don't know that it'll ever end, but it is enlightening to see, or it's refreshing rather, to see the changes that have just from when I had my baby till today. Like we didn't have things like this, where there's actually people that would invite mothers who have had substance exposed babies to talk. And like you guys are all really kind and caring and listening and asking really good questions too. Thank you.
I agree. I don't think it'll ever go away. I think it's never going to change. Like stigma might not always end, but I think the more that we are out loud about not only our struggle, but how we recovered from our struggle and what helped and what hurt, I think the more open conversation in communities or societies or healthcare is gonna ultimately make the difference. Like Amanda said, there wasn't people. Everything was to be anonymous, even when you recovered. Back when I first entered recovery, right? That you were going to hide shamefully while you recovered as well. And so there was no hope out there. It could have been my very own therapist that was recovering from drugs, but I wouldn't know because she was in an anonymity kind of program. So the hope, I think, is spread by our openness, that it's like it's not going away, right? You can't sweep it under the rug. Like this isn't going to happen if we don't talk about it, because it's going to. Substance use disorder is going to continue. And the more we're open about it, that it's a reality in life, I think the more solutions will come from that. The more people that are willing to listen can help us on those suggestions, as well as people with lived experience knowing what's going to work and what's not. That combination is powerful. I think it's making a difference every year.
As an adolescent therapist, is there anything you can recommend that maybe you did not receive in ages 11 to 18-ish that would have helped?
I think someone to relate to, right? If I had been, because I was at like 13, 12, really, really struggling and trying to get help before I was homeless. And I didn't know of other kids that were going through the same thing, right? Other than the kids that weren't trying to get better. So I think as a therapist, maybe like some group peer led, when you have a success story, a child that's doing well, come back and talk to the other kids. That is possible. Like instilling hope is going to be really helpful.
I think for me, exposure to other settings where it's not so normal for everybody to be using substances. Like that's not what everybody does. Well, it was in my life. And harm reduction, again, because just say no is not real life for me. And so understanding the types of harms that the substances can cause and having an alternative for like other ways to cope with my mental health issues, or, especially like the anxiety and like the social awkwardness. Teenagers are hard and they're extra hard if you don't have any support to teach you how to interact with other people, and substances were my answer then. So I think helping them build that capacity within themselves would probably be cool.
Thank you both so much. What do you do for self-care?
Meditation, journaling, keeping open communication with my therapist. My RCO gave us gift certificates to get our hair done. Taking vacation days when needed, right? Sleeping, taking a bath, reading your own body and knowing when you're starting to feel overwhelmed. If I'm feeling burnout, say I'm working with some folks as a coach, and not a lot of them are doing as well as I would be hoping for them. And if I start to get discouraged, then I attend a training. Peer 360's trainings have always been a great way of self-care and refreshing and avoiding burnout for me.
For me, a lot of My self-care is just like taking care of my responsibilities, having things set up to where I have to get out of bed sometimes because I'm really good at staying in bed or like watching a TV show for hours or, disconnecting. But for me, my self-care is to kind of stay connected, by having some balance in that. So knowing when I need to take a rest. We do a lot of trips. We go out of town a lot, have things to look forward to, setting goals and having things to work towards. Those are all self-care things for me.
In my experience, many therapists or counselors advertise as substance use disorder treatment professionals. Most are not passionate about this or well-versed. Did you guys come across this over the years? How can we help substance use disorder neonatal mothers find appropriate professionals or agencies to help in this arena?
Many, many, many times. It takes a really long time sometimes to find the right fit. Even if they are passionate about it, sometimes it's just not a good fit. But for me, word of mouth has been the most powerful thing, like checking into those resources, finding out exactly what they offer, what kind of credentialing they have, because that's different from place to place also. And just being willing to walk with them as they make those calls, asking good questions, writing down a list of things that you hope for or things that you need to expect. Yeah, that was the best answer I got for that one.
I want to agree. I like when Amanda said like the walking with them. I think if a therapist does not have any experience of their own with having a substance use disorder, or maybe doesn't have close family or an understanding on that like personal level, attend some meetings. Go check out in your community like meetings and get one-on-one with these folks without it being a therapeutic session to get them to know them as people, and you kind of develop an understand a little bit of more of an understanding, I think. I've had therapists that for me, it worked well if they had um, relatable experience in either having SUD or having someone close with SUD. Um, Having lived experience was key to me to have a relatable relationship. But for the ones that were just passionate, I could tell because they were involved in their community with those folks, right? Maybe in recovery courts. Maybe they're going to deal with folks that are, have friend of the court involved or CPS and having a relationship with them other than just the sessions, like on a more face-to-face level without it always having to be your job. I guess. I don't know.
Thank you both so much. As a former foster parent, I'm curious if you were able to keep contact with them as a form of support for yourself and your children, or were you able to request the same foster placement for your children? How can foster parents support you better?
Thankfully, my children were placed with a family member. She wasn't a close family member, but she was an amazing person that was willing to take in 4 small children and have her life turned upside down. She was super supportive throughout the process. And actually, my daughter is going to spend the weekend with her this weekend. So we talk all the time. It's been pretty cool.
Mostly my mother was my foster care provider. However, my third or my very last baby that was born opiate positive with a nose, my mother would not take her. She would take my other children and not that baby, partially because she was a newborn, but also because she was struggling with NOS. And so I did have a really great foster care parent. I didn't like her in the beginning. As I said, she was throwing out my breast milk and she was not being really she wasn't open to information about addiction or withdrawal or any of these things that she just wanted to care for the baby and didn't put the two together. But over time, she ended up having my youngest for over a year of her life. And at the end, when I had reunified with all my children, had offered like, let me just take the load off, right? You're a single mom with all these kids. Let me just, there was laws, I believe, that would have prevented her from keeping in contact with us for whatever reason. But we did maintain contact. She stopped fostering because of her connection with my daughter and not being able to keep her, right? It was very hard for her, that bond. And so she did stop becoming a foster mother, but she gets my daughter twice a month I have kept her in our family. She raised my baby during such a difficult time that she is family to me. So I talk to her weekly or every other day at times. And she's like another family unit for my daughter still today, which I'm very, very grateful. And it was because she did decide to learn, how to work with someone who's in and out of active illness. She did that on her own so she could understand. And so we've been able to grow because of that. And she's a pastor in her community, and she helps talk about that now to other folks who foster kids. So she won't take any more children, but she's going to help those that do, which is nice. So it's a ripple effect, I think.
So, can we somehow put together the substance use disorder prenatal options within Michigan? Kelly, we can look into that and see. We do have a bunch of resources on our website about substance use disorder and pregnancy. We also have a perinatal substance use disorder project ECHO that meets once a month, the second Wednesday of the month. And we do talk about resources and things that are available within the community that can help patients. So that's an option as well. And that looks like we made it through all of the questions with 1 minute to spare. Woohoo! So thank you all so much for joining us. Thank you so much, Dawn and Amanda, for sharing your stories and for answering all of our questions. Much deserved kudos to the both of you for sharing your wonderful recovery journey with us. We really appreciate it. Dr. Cooper, thank you so much for joining us and for giving us the presentation on NAS Nows. We really appreciate that as well. For all of you who called in, all your attendees, thank you for joining us. You will be getting if you signed in with your email address in the chat, you will be getting a follow-up email with links to do different evaluations based on the CMEs or the CEUs that you're wishing to get afterwards. So please look for that email to come next week. And we will send out the PowerPoints with that email as well. And I think that's everything. So thank you everyone so much for joining us today. And thank you for helping us to educate on substance use disorder during pregnancy.
Thank you, Kim.
Thank you, Kim and Trisha and Jeff, and then everybody for listening with an open mind and just even having an ear for this is amazing. Thank you so much for having me.
Thank you for sharing your stories.
Thank you.
Thank you both so much.
Thank you, everyone. Have a great day.
Thank you.